Recording in
Yes, sir.
progress.
Please start the session, sir.
Okay, so am I?
Yes, the slide is visible, Dr. Mrityunjay.
Okay. So may I start, sir?
Yes, sir. Yes, sir.
So at the outset, I would like to thank the organizers of Apicon, Apicon Odisha 2022 for inviting me for this talk. And my talk is Management of Hypertension in CKD. Slide is moving?
Yes. Yes.
Moving, okay. So hypertension is common in patients with chronic kidney disease and is the most important modifiable risk factor for CKD progression and adverse cardiovascular event in these patients. But the problem is that there is a suboptimal BP control. BP control is not up to the mark, and that leads to 62% increased risk of cerebrovascular disease, 49% of ischemic heart disease, and 7.1 million deaths worldwide. So suboptimal BP control is the problem. And if you will see this quick study, visible, sir?
Yes, go ahead.
So, okay. So this, if you will go by this quick study, then if BP control, if you take the BP control as less than 140 by 90, then only 67% of the patient having this control. And if we go for more stringent control, like 130 by 80, then only 46% of the patients are having this BP. So I will start my talk with this outline: BP measurement option, BP target, management, non-pharmacology, and pharmacology. My talk is based on KDIGO guideline 2021, where they have given more importance to this BP measurement option, which was not in the earlier guidelines. And then BP target has also somewhat changed. So you will see some new changes in this guideline. So if we will see the BP measurement option, we have many BP measurement option, like in clinic BP, home BP. In clinic BP, casual office BP and standardized office BP measurement is there. But in this guideline, they say that they recommend that standardized office BP measurement is preferred over routine office BP measurement for the management of high BP in adults. So we should do a standardized office BP measurement. What is this standardized office BP measurement? There are certain prerequisites for this standardized BP measurement. We all know that. And I will take few minutes here to elaborate you on this standardized office BP. Patient should sit relaxed, should empty his bladder. There is no smoking, caffeine, or exercise for more than 30 minutes before measurement. Should avoid, at the first visit, we should record BP in both the arm, and we should always keep two measurements separate by 1 to 2 minutes and take average of that BP. And we should also see for the cuff size. So this is very important because standardized office BP measurement has the cornerstone for the management of this hypertension in CKD. So what is the advantage of this standardized office BP? Because this BP measurement has been employed in mostly larger studies like ACCORD and SPRINT, and it minimizes misclassification and over-treatment or under-treatment of high BP. Although it is cumbersome, but we should always prioritize this standardized office BP in our day-to-day practice. Disadvantage is that it requires staff training and retraining and require more times of patient, providers, and staff. So now coming to this ambulatory BP measurement, which is only supplementary to this office BP measurement. And if we combine both of these, office BP measurement and this home BP measurement, then we will come with various phenotypes of BPs, like this white coat hypertension or white coat effect, sustained hypertension or sustained uncontrolled hypertension, masked hypertension or masked uncontrolled hypertension. We also get information about these deepers, non-deepers, and nocturnal rise in BP. And why this is important? Because abnormal BP pattern is very much prevalent in this CKD patient. We can see here that white coat hypertension is prevalent in 3 to 41% of the patient, masked hypertension in 6 to 50% of the patient, non-deepers are 30 to 50%, and nocturnal rise is 10 to 35% of patient. And it has been seen that this masked hypertension, non-deepers, and nocturnal rise is associated with poor CV and renal outcome in CKD patient. So blood pressure measurement practice point is that we should always do a standardized office BP. we can use oscillometric BP measurement or this automated BP measurement. What is the benefit of this automated BP measurement? It may increase the likelihood of adherence to proper BP protocols, removes potential source of inaccuracy with manual measurement, may reduce white coat effect, frees staff to complete other duties used in prior RCTs and prospective cohort studies. But the most important thing is proper preparation. Proper preparation is very important for this standardized office BP measurement. Now coming to the BP target, there are debate over years over this intensive versus standardized BP targets in kidney diseases. And the advocates of this intensive BP target says that it decreases mortality, it decreases CV event, but the opponent says that it increases the risk of syncope, hypotension, decreases the risk of AKI and electrolyte abnormalities. It decreases adherence. It also promotes polypharmacy, and moreover, it also increases healthcare utilization. And if you will see the various trials over the years, till 2010, we have 4 trials, major trials, on which renal protection has been shown in this MDRD, REIN2 and ASK trial, and this cardioprotection has been the primary endpoint in ACCORD trial. And according to these all trials, these 4 trials, standardized this intensive BP control is only benefited to the patient who are having more proteinuria, more than 1 gram per day proteinuria. So they are advocating about the standard BP control, which is intensive BP control in certain subset of patients where there is more proteinuria. But the things have changed after this sprint trial. So you will see that in 2012 guideline, on the basis of these trials, they have given that if patient is having albuminuria less than 30 mg in 24 hours, you should go for less than or equal to 140/90. And if albuminuria is more than 30 mg in 24 hours, you should go for less than 130/80. But this sprint trial, where they have also accommodated these CKD patients, these high-risk CV patients, and it has 2 arms. Intensive arm is where target is less than 120, and standardized treatment where target is less than 140. And the highlight of the sprint study is that intensive reduction in systolic blood pressure reduces cardiovascular events, intensive reduction in systolic blood pressure and mortality benefit in CKD populations. The subgroup analysis of older patients with CKD in sprint has also favorable outcomes. And so with adoption of this systolic BP less than 120 mm of Hg in all CKD population, separate blood pressure target for proteinuria is not required. So you will say that this ACCORD and sprint are not on the same page. But if you will analyze this, you will find that they are on the same page, because ACCORD did not include the patient with serum creatinine above 1.5 mg per dl. But you have to mind that ACCORD has a factorial design where they have kept 2 things, BP control and glycemic control. And in the subset of patient where there is a standardized glycemic control has benefited with this intensive BP control. So the patient in ACCORD who are having stringent blood sugar control are only having high mortality with stringent BP control. But the patient who are having this standardized glycemic control have benefited from this stringent BP control. So again, the meta-analysis of trials over the years have shown that more intensive BP control is associated with lower mortality risk among trial participants with hypertension and CKD. So one important thing is that the opponent says that it increases the risk of CKD progression with intensive BP control. But it has been seen that with intensive BP control, there is an initial drop in GFR, but without increase in tubular injury markers, and initial decrease in this GFR is retarded over the years. And if you will extrapolate these studies over the 20 years, then this would only cause a 3 ml minute difference of this GFR. So by reducing only 3 ml eGFR in 20 years, if you are getting more mortality benefit, if you are getting more CVD benefit, so we should go for this intensive BP control in this CKD patient. And on the basis of this, recommendation says, KDIGO 2021 recommendation says that adults with high BP and CKD treated with target systolic BP of less than 120 mm of Hg using standardized BP measurement. But groups where we should be liberal, like CKD stage 4 or 5, advanced CKD, diabetic patient, individual with systolic blood pressure in the range of 120 to 129, patient with very low baseline diastolic BP, specific etiology of CKD, severely increased proteinuria, older age or younger age, and very frail patient, white coat hypertension, severe hypertension. In these patients, we should be little liberal. Now, you should understand that BP targets should be individualized in this patient. Now, coming to the management of hypertension between non-pharmacological therapy, pharmacological therapy, and newer therapies. Lifestyle management for lowering blood pressure in dialysis CKD patient is salt intake should be reduced to 2 grams per day, equivalent to 5 grams of sodium chloride. Dietary sodium restriction is not appropriate for salt-losing nephropathy. DASH type of diet or using salt rich in potassium may not be appropriate in advanced CKD or those with hyporeninemic hypoaldosteronism because for potential for hyperkalemia. Again, moderate intensity physical activity with 150 per minute week is suggested for hypertensive CKD patient. Looks for cardiorespiratory fitness, physical limitation, cognitive function, and risk of all modify the intensity and duration of physical activity. Now coming to the pharmacotherapy, so let us first see how we stage the CKD. You can see here in the horizontal plane, on the basis of eGFR, we can have 5 categories like CKD G1, 2, G2, G3A, G3B, G4, and G5. And on horizontal plane, we categorize into 3 parts on the basis of albuminuria, A1, A2, and A3. And blood pressure management is based on these both criteria. Like recommendation is that if patient is having G1 to G4 and A3 means heavy proteinuria, if patient is also without diabetes and patient is having CKD, we should recommend RAS inhibitor. We should give our patient RAS inhibitor. Again, recommendation is that we suggest starting RAS inhibitor for people with high BP, CKD, and moderately increased albuminuria, G1 to G4 and A2 without diabetes. With diabetes, we should also start RAS inhibitor. So what is the practice point? Practice point is that it may be reasonable to treat people with high BP, CKD, and no albuminuria with or without diabetes with RAS inhibitor. RAS inhibitors should be administered using the highest approved dose that is tolerated to achieve the benefit described because the proven benefits were achieved in trial using these doses. Again, practice point 3 is that change in BP, serum creatinine, and serum potassium should be checked within 2 to 4 weeks of initiation or increase in the dose of a RAS inhibitor depending on the current GFR and serum potassium. Practice point 4 is that hyperkalemia associated with use of RAS inhibitor can often be managed by measure to reduce the serum potassium levels rather than decreasing the dose of stopping RAS inhibitor. Again, practice point 5 is that continue ACE inhibitor or ARB therapy unless serum creatinine rise by more than 30% within 4 weeks. Very important. Following initiation of treatment or an increase in dose. Because if you will start a patient on ACE inhibitor or ARB, initially there will be rise in serum creatinine, but it is not the criteria for stopping the ACE inhibitor or ARB. Consider reducing the dose or discontinuing ACE inhibitor or ARB in the setting of either symptomatic hypotension or uncontrolled hyperkalemia despite medical treatment to reduce uremic symptoms while treating kidney failures. Mineralocorticoid receptor antagonists are effective for managing the refractory hypertension but may cause hyperkalemia or a reversible decline in kidney function, particularly among patients with low eGFR. So, blood pressure management in patients with CKD with or without diabetes not receiving dialysis, we recommend avoiding any combination of ACE inhibitor or ARB and direct renin inhibitors therapy in patients with CKD. So, ACE inhibitor or ARB or ACE inhibitor ARB with DRI is not recommended in any patient of CKD. So, we are very much concerned about this RAS inhibitor because RAS inhibitor has shown to cause AKI. One potential problem is with this agent is that. So recent guidelines suggest, as I have shown, that 30% increase in serum creatinine in first few weeks and later on stabilization is an acceptable physiological change which confers long-term renal protection. We should always rule out diuretic-induced hypovolemia, renal artery stenosis, and concomitant NSAID use in this patient before stopping RAS inhibitor. And we all know that ACE inhibitor, ARB are very important for treatment of CKD, but hyperkalemia is one of the main determinant which propel us to stop these drugs. but we should always rule out pseudo hyperkalemia, restriction of dietary potassium, discontinue drug containing potassium salts, add potassium wasting diuretics with RAS inhibitor, and add oral potassium binder with RAS inhibitor, so that we can continue with this RAS inhibitor because they are shown to have greater benefit in CKD patient progression. And we have newer this potassium blocker, potassium binders, which can be given up to 1 year. And with this, we can continue this RAS inhibitor, but still this is in pipeline, not used on the not used in the clinical practice. Now coming to another good drug, calcium channel blocker. It can be used as a first-line therapy in non-proteinuric CKD, either alone or in combination. As far as proteinuric CKD is concerned, ESC or ESH guideline advocate combination of ACE inhibitor with CCB as the first-line therapy. A major advantage of using this combination is that they work well in a volume expanded state. Now coming to diuretics, they have got antihypertensive effect with preserved and that is preserved in higher CKD stages. So this is not that thiazide diuretics should not be used in advanced CKD. If you have to control hypertension, we can also use thiazide diuretic in CKD stage on stage 3 and stage 4 as well. They can be used well in volume overload state because most of the CKD patients are having volume overload. But they should not be used in ESRD with minimal or no residual renal functions. And we should not use them in polycystic kidney disease. Now coming to this mineralocorticoid receptor blockers, and there is a growing interest in using these drugs with ACE inhibitor on ARB to reduce proteinuria and BP. But hyperkalemia is the major limiting side effect. But this Fidelio trial for kidney and CBD protection, which has come recently, has shown that this finerenone slows the progression of CKD and reduces cardiovascular mortality in patients with type 2 diabetes. Now, coming to the combination, because CKD often require combination therapy, we can use various combinations, but we cannot use ACE inhibitor with ARB, as I have already said. But the good combinations are where ACE inhibitor can be used with thiazide diuretics, calcium channel blockers can be used with thiazide diuretics, and ARBs can be used with all these. Now coming to one important combination, this is very important, RAS inhibitor with SGLT2 inhibitor, because we all know that this SGLT2 inhibitor causes vasodilation of this afferent, this also causes afferent arterial vasoconstriction, and this RAS inhibitor causes vasodilation of efferent arteriole. So if we will combine these two drugs, we can decrease intraglomerular pressure to a major extent, and it can benefit our CKD patient. So many of the nephrologist colleagues are using this combination in our CKD patient. Now this is the central illustration. So you have to keep, standardized office BP measurement. We have to do standardized office BP measurement. We should always tell our patient to having lifestyle modification, and adult with CKD with or without diabetes, systolic blood pressure should be kept below 120 mmHg, and we should use ACE inhibitor or ARB in G1 to G4 patient, and whether A2 or A3, whether albuminuria is in A2 or A3 level, means 3 to 30 or more than 30. So conclusion is that the prevalence of hypertension in CKD is very high, but hypertension control rate is far from optimal. Maintaining systolic blood pressure goal of less than 120 mmHg using this standardized office BP measurement is strongly recommended by KDIGO guideline 2021 in most of the CKD population. Controlling hypertension in CKD not only slows the progression of renal damage, but reduces the risk of cardiovascular disease. ACE inhibitor, ARBs, appropriate diuretic therapy, and dietary salt restriction make up the foundation for the treatment of hypertension in CKD. Thank you very much. I will happy to take questions.
Thank you, sir. Thanks a lot for your lucid and very informative speech. Thank you. Thank you, sir. Now I request Abhay sir. He is the former professor and head department and principal Honorary Magatha Medical College Gaya, past chairman API Bihar chapter, past president CSI Bihar chapter, past vice dean ICP, past president HIS, past president CCDSI. I request sir to give his speech on hypertension in elderly.
Thank you. Thank you. Just I'm going to share the slide. Is it visible?
Visible, sir.
Okay. At the outset, I'm going to thank Dr. Jan Panda for giving us opportunity to give talk at Apicon, Odisha 2022. My topic is hypertension in elderly. Hypertension is now increasing in epidemic proportion. Today, approximately 1 billion people worldwide have high blood pressure, and this number is expected to increase to 1.56 billion people by the year 2025. That translates to about 1 out of every 4 adults being affected with the hypertension. Rising hypertension in India. In the last 6 decades, hypertension increased 30 times. Hypertension is directly responsible for 57% of all stroke deaths and 24% of all coronary disease deaths in India. Rising number of young hypertensive. This is of great concern. Epidemiology of hypertension elderly. Elderly have certain changes in their physiology. And what are these changes? In men and women, free of hypertension at the 55 years of age indicate that the remaining lifetime risk for developing hypertension through 80 years are 93%, 91% respectively. It means as the age grows, the incidence of hypertension is bound to increase. In other words, more than 90% of individuals who are free of hypertension at 55 years of age will develop it during the remaining lifespan. Hypertension prevalence is less in women than in men until 55 years. It is equal between 45 to 64, and after 65 years, it is more in female. Does elderly hypertension have specific characteristics? This was I was telling. Why we have rising in systolic hypertension in elderly? It is because of these causes. The first is increased systolic blood pressure and pulse pressure, left ventricular mass and wall thickness, arterial stiffness, calculated total peripheral resistance, decreased cardiac output and heart rate, renal blood flow, plasma reactivity and angiotensin II level, arterial compliance and blood volume, and diastolic blood pressure. So the characteristic of hypertension in elderly is there is rise in systolic pressure and there is a fall in diastolic pressure. And this happens because of certain changes. And what are the pathophysiology? The first, why it is happening? Because of the arterial stiffness, neurohormonal and autonomic dysregulation, and the aging kidney. Elastic artery shows 2 major physical changes with age: stiffness and reduced elasticity. Aorta and the proximal elastic artery dilate by only 10% with each beat of the heart in youth, while the muscular artery dilate only 3% with each beat. During systole, the arteriosclerotic arterial vessel exhibit limited expansion and fails to buffer effectively the pressures generated by the heart, causing an increase in systolic BP. This is the reason. Arterial stiffness is the reason of increase in the systolic BP. On the other hand, the loss of recoil, elastic recoil during diastole result in reduction in diastolic BP. So rise in systolic BP is due to arterial stiffness, and fall in diastolic pressure is due to loss of elastic recoil. Arterial wall compliance and pulse pressure is the same thing which is saying elastic vessels and stiff vessels, same thing. Now, this slide shows with the age, there is a rapid rise in systolic BP. And this you can see at the age increases. At the age of 80, it is 93%. So gradually rise in systolic BP pressure as the age increases. Pathophysiology control, neurohormonal and autonomic dysregulation. The second cause of this hypertension is neurohumoral and autonomic dysregulation. Renin-angiotensin system decline with the age. Plasma renin-activity at the age of 60 years is 40% to 60% of the level found in younger individuals. The aging kidney. The aging kidney is characterized by progressive development of glomerular sclerosis and interstitial fibrosis, which is associated with decline in GFR and reduction of the other homeostatic mechanism. Diagnosis and classification of hypertension. This you all know. I'm not going to tell. And what I'm going to tell you that any person having above 140 systolic and diastolic 90 and above are classified as hypertension. But high normal should be treated as a pre-hypertensive, that is systolic between 130 to 39 and diastolic 85 to 89. This slide shows blood pressure is causing highest mortality. If you compare tobacco, high cholesterol, underweight, unsafe sex, high BMI, physical activity, alcohol, indoor smoke, and solid fuel, iron, out of all these, blood pressure is the leading cause of the mortality. Now, biggest concern today is not hypertension comorbidity, because hypertension is not associated with alone. It is associated with comorbidity, especially in elderly. And these comorbidity increases the morbidity and mortality. And if there is no risk factors, the mortality and morbidity is very low. And as the risk factor increases, you can see, go through this slide. All grade of, depending upon even in the grade 1 hypertension, if the patient has CKD, even grade 1 hypertension, mortality and morbidity increases. So, associated risk factor increases the mortality and morbidity and mortality in grade 1 hypertension. While a person having no risk factors, the patient can tolerate, and mortality and morbidity is less in grade 1 but is high in grade 2 and grade 3. Management of hypertension in elderly patients. We all know the first is non-pharmacological therapy, and second is lifestyle modification, and second is pharmacological therapy. Now, BP goal. What is the BP goal? 2014 hypertension guideline, population general less than 60, it is less than 150 by 90. General less than 60 years, less than 140 90. Diabetes and kidney, it is less than 140 by 90. But as Dr. Mithunjay said, most of the other guidelines now accept that the BP should be less than 130 by 80 in diabetes and kidney and CKD. Benefit of treatment. Younger than 60, reduce in the person younger than 60 years, reducing BP by 10 by 5 by 6, 10 systolic and diastolic 5 by 6, reduces the risk of stroke by 42%, reduces the risk of coronary event by 14%. Older than 60 years, reducing BP by 15 systolic and 6 diastolic, reduces overall mortality by 15%, reduces cardiovascular mortality by 36%, reduces incidence of stroke by 35%, reduces coronary artery disease by 18%. Now, lifestyle modifications, you can see what are the exercise, weight reduction, stop smoking, reduce smoke, and diet control, reduce salt. And weight reduction, by weight reduction, 10 kg reduction reduces the BP by 5 to 10 millimeter, systolic BP by 5 to 10 millimeter mercury. Dash diet adoption, 8 to 14 millimeter. Dietary sodium restriction, 2 to 8 millimeter. Physical activity, 4 to 9. And moderation of alcohol 2 to 4. So if you combine all together, minimum 21 millimeter to maximum 55 millimeter can be reduced only by lifestyle modification. That is why in stage 1 hypertension, before starting medicine, we always advocate lifestyle modification in all age group. Aggressive management of elderly, primarily systolic hypertension, they have systolic. The first is lifestyle changes. Second is low dose diuretic, because these patients are very prone to hyponatremia. So low dose diuretic, and if the BP is not controlled, then we can add calcium channel blocker or AC inhibitor ARB. Beta blocker are only added when there is a specific indication or if the BP is not controlled. And the most important is about the dose increase. Don't increase the dose so quickly, because in elderly, if you increase the dose, there is chance of sudden fall in BP or postural hypertension, because bioreceptors takes time to reset. So you have to increase the dose gradually. Otherwise, the patient will have hypertension, especially postural hypertension, fall and fracture. So this is very important, especially in elderly. And these are the drugs, antihypertensive, you all know, diuretic, beta blocker, ACE inhibitor, ARB, cancer channel alpha blocker. We all know about this. Al-Hayat study, this is very famous study. Al-Hayat, the antihypertensive and lipid lowering treatment to prevent heart attack trial suggests that low dose thiazide diuretic have a better cardiovascular protective effect. And the result highlight of that study is 21% reduction in relative risk death from any cause. So 21% reduction in relative risk of death, 64% reduction in relative risk of heart failure, and 39% reduction in relative risk of death from stroke. So these are the major benefit shown by Al-Hayat trial. This is one famous EUR trial. A study called the systolic hypertension trial in Europe showed that aggressive treatment of hypertension reduces the risk of stroke by 42% and dementia is prevented. Because dementia is one of the major complications of hypertension in elderly. So by controlling BP, we can reduce the incidence of dementia. Hypertension in the very elderly trial, highway trial. This is a famous, very famous trial. These are the characteristics. I'm not going in detail of the characteristics, but what was the result? Result highlight showed there was 21% reduction in relative risk of death from any cause, 64% reduction in relative risk of heart failure, and 39% reduction in relative risk of death from stroke. So these are the very famous trials, and they also that if you control the BP in elderly especially, it is in all age group, but there is a 21% reduction in any cause of death, 60% reduction in heart failure, and 39% reduction in death of stroke. So these are the very important features, advantage of controlling BP in all age group, especially in elderly. Meta-analysis of the hypertension treatment trial of people above 80 years of age. And again, this shows there was a stroke reduction in 34%, CSD reduction 22%, heart failure was 39%. So maximum reduction occurs in heart failure, followed by stroke, and then CSD, coronary heart disease. Take home message. Hypertension is an important risk factor for cardiovascular morbidity and mortality, especially in elderly. Majority of the elderly have isolated systolic hypertension. That the BP goal in elderly is less than 150/90. Hypertension treatment reduces stroke by 38%, heart failure by 40%, CAD by 22%. It also reduces dementia in elderly. Thank you very much. Am I audible? I finished.
Thank you, sir, for a very clear and lucid presentation. It was really very enlightening to hear from you. And thank you very much, sir.
Thank you.
Thank you, sir. Sir, we'll move into the next section. The next presentation will be by Dr. D.P. Singh, Professor and HOD of Respiratory Medicine, JLN Medical College, Bhagalpur. And he was the governing body member of the National API 2015 to 23, Chairman of IMA Academy Bihar Chapter 2017-23. The topic for today is undiagnosed pleural effusion. Professor D.P. Singh, sir.
Is it visible?
Yes, sir.
Yes, it is now full screen. Can you make it full screen, D.P. Singh?
Is it visible, sir?
Yes, sir.
Yeah.
Yes, sir. Visible, sir. Sir, kindly make it a full screen, sir.
It is full screen. I have made full screen. It is
No,
not
no.
there.
No, it's not.
Full screen.
Slideshow, sir. Slideshow.
It's not full screen.
Is it there, sir?
Not yet.
Order में कुछ कम.
Sir, visual audible, but half screen. You have
Sir,
to
just-
just full screen, slide slow.
Just press F5, it will be on full screen mode.
पीछे कुछ करना पड़ेगा. बोला मैं उनको.
Sir, you see the home insert design option. There will be a
Home.
slideshow. There will be a slideshow option.
Then that is there. Is it full show now?
No,
sir.
not yet.
Not yet, sir.
आगे पीछे करिए ना उसको full से.
बच्चा को बुला के स्विम करवा मैं तो लोगों को हो सकता है आता हो.
नहीं हम लोग पहले भी किए हैं.
Go to home screen.
Sir, you reshare, sir. You reshare.
Okay.
Yes, sir. Yes, sir. Now it's full screen, sir.
No, not yet. It's not slide. No,
Oh, it's only the camera, sir.
camera.
Camera, sir.
कहाँ जा रहे हैं? इसको दोनों में से ये पहला यहाँ से करिए करते हैं.
नहीं है सब कुछ.
Is it full screen now?
No,
Not-
sir.
I think you go ahead because
Sir, we can proceed, sir.
we can proceed.
We can adjust.
Yes, sir. We can proceed, sir.
नहीं. जो आप करते हैं अच्छा फिर बैक करिए.
नीचे में
ऊपर में इसका कप वाला नहीं है, ऊपर ही है, होम में है,
नीचे में है सर. नीचे में है.
नीचे में है.
हाँ नीचे में है. यहाँ पे दिख रहा है नीचे में.
इससे करिए.
Sir, just press F5. Are you getting my voice, sir?
F5 of your keyboard.
Press F5 on keyboard.
F5 कहीं है? Oh, YouTube.
Keyboard F5.
F5 करें.
सर नीचे के कॉर्नर के साइड पे देखिए, वहां पे 82% जहाँ पे लिखा है ना, उसके
हाँ।
बगल वाला आइकॉन पे क्लिक करें.
राइट साइड कॉर्नर पे सर, जहाँ 82% लिखा हुआ राइट साइड नीचे कॉर्नर पे, वहां पे एक है सर. वहां पे भी आप
सेटिंग अच्छी फुल स्क्रीन
हाँ बस उसको
बस प्रेस करें.
We have done it. Yet not. Hello.
हाँ नहीं है.
It is full screen.
Not yet.
Not yet, sir.
I think you should go ahead.
Yes, sir. We can proceed, sir. It's okay, sir.
It is visible.
It's visible, sir.
We can adjust.
Sharing कुछ कर रहे हैं गड़बड़. Stop.
नहीं सर फुल स्क्रीन.
Full screen नहीं है, ये नहीं हो रहा है ना. Stop sharing करके फिर से करें. Stop share. Present की करिए. आगे पीछे. पहले यहाँ से करें. यहाँ ये इससे करें. नहीं होगा.
क्या नहीं हो रहा?
फुल शेयरिंग नहीं हो रहा है.
Capacity सांगा वो ये करें.
ये अच्छे से
सब कुछ स्क्रीन शेयर करेंगे क्या?
शेयर करेंगे. फुल शेयर.
अभी पूछो अपन से.
करिएगा.
Yes, sir. Now it's
हाँ yes.
now it's full screen.
Yeah, now it's
हो गया
full
सर, हो
screen.
गया.
So, good morning, everybody. Our honorable chairperson, our doyen of API and CCDSI, Dr. A.N. Reiser, and every friends in this hall. So after the session of hypertension, let us move to very important topic, or rather the very important organ, that is lung, which is housed by two layers of pleura. And in that, we have got collection of fluid, and in which the diagnosis may be sometimes different. And in those areas where we are not able to...
Change your slide, please. Slide is not moving.
Oh, yes, sir. Sir. This is a pleural effusion, collection of fluids, and in which we are not able to diagnose. And there are more than 60 causes, and out of which there are few causes in which are very common, and we are not able to pick up the diagnosis in those. And we are going to deal with those, how to diagnose the undiagnosed pleural effusion. And there is no universally accepted definition of undiagnosed pleural effusion. Almost 25 to 40% of the patients remain undiagnosed in this pleural effusion. And if you see, remember, Sir William Osler, he says there are only three things are important in medicine: diagnosis, diagnosis, and diagnosis. And in diagnosing a patient of pleural effusion, we must take the clear-cut, thorough history, physical examination, and lab investigations. And in case of pleural effusion, imaging is very, very important. You know that any patient suspected to have pleural effusion, we do the chest X-ray, we do the ultrasound, because even the small pleural effusion can be picked up by the ultrasounds. And then if it is not diagnosed by that, thoracosynthesis we do, pleural fluid analysis we do, Light's criteria we analyze, and even after that we are not able to diagnose, we go beyond that. And what is we are going beyond that thoracosynthesis, we shall see. These are the very common causes of pleural effusion, and we divide this transudative as well as exudative pleural effusion. If you get this transudative pleural effusion, it is the domain of physicians. It is the domain of the systemic diseases like congestive heart failure, cirrhosis of liver, nephrotic syndrome, and these are very easily diagnosed. But the local causes, tuberculosis, pneumonia, malignancy, pulmonary embolism, this is sometimes difficult to diagnose. And there are many other causes. So if you take the proper history, if anybody exposed to asbestos, this occupation, the mesothelioma could be a suggestive diagnosis. Similarly, a patient having fever means the infective origin of cases like tuberculosis or pneumonia or other abscess should be there. A history of this rheumatoid arthritis will pinpoint towards this collagen disease as a cause of this. Similarly, different history like the clinical examination. This crackles, S3 gallop, neck veins engorged, that will suggest the diagnosis of congestive heart failure. Similarly, the unilateral lower limb extremities, pulmonary embolism will be the cause of the pleural effusion. So the physical examination again is very, very important. Chest X-ray and lateral decubitus, that should be the initial stages in which you can diagnose and pick up the pleural effusion. This is this Ellis curve and the costophrenic angle obliteration. And this is the lateral decubitus. You can find if it is more than 1 centimeter, you take up the fluids for diagnosis. Imaging, again, spiral CT scan of chest help in the diagnosis of pulmonary thromboembolism. Even the pleural masses, mediastinal masses, lymphadenopathy, lung infiltrates can be picked up by this CT scan thorax. Echocardiogram also reveals the pericardial disease as well as cardiac images being this congestive heart failure being the cause of pleural effusion. Let us take an interesting case one in which a 33-year-old male presented to our hospital with a history of sudden onset of chest pain, pleuritic, right-sided chest pain of 2 days duration. He was a smoker. Breath sound was absent in the infrascapular and inframammary axillary areas on the right side. And this was the chest X-ray showing the costophrenic angle obliteration in the both sides. Right side is more, left side it is small pleural effusion in there. So bilateral pleural effusion that are unequal size, unresponsive to therapy, and associated with pleuritic chest pain or fever should be subjected to diagnostic thoracentesis. And what all this says, the pleural fluid protein is high, LDH is also high, and pleural fluid is clearly exudate. So where to go? Light's criteria, this Richard Light in 1972 gave this criteria, and this signifies or this classifies pleural effusion into exudate and transudate. this LDH by serum LDH level more than 0.6, pleural protein by serum protein level more than 0.5, and pleural LDH level more than 2/3 of upper limit of the normal. Absence of all this is transient, and it has got sensitivity and specificity more than 98%. And then pleural fluid ADA level, again, is very important, because if it is more than 40-45, this indicates diagnosis of tuberculosis in 90%. But mind it, it is not that diagnostic. Empyema may also have this ADA level high. Paranemonic effusion can have 30%. Malignancy also 5% patients can have. Even rheumatoid arthritis can have this. So it is not diagnostic. So we have to find out the clear-cut diagnosis by other means. Cytology, again, that will be very important in malignancy. And there are other tests also, especially amylase will pointing toward the malignancy or pancreatic disease. Anti-pro-BNP levels should be investigated, especially if we suspect the congestive heart failure as a cause. CD-NAT in the pleural fluid usually present only in small cases, 25% or so, because pleural effusion in tuberculosis is hypersensitivity reactions, and tubercle bacilla may not be there, not giving much of the positivity in that. If you take the cells, the lymphocytes, more than 50% suggest not only tuberculosis, maybe malignancy, maybe pulmonary embolism, maybe coronary artery bypass surgery. So not many tests that you can't base that these cells are there, so it will be tuberculosis or other things. So exudative pleural effusion, among the causes of exudative pleural effusion, tuberculosis, malignancy, pulmonary embolism should be considered in every patient with undiagnosed pleural effusion. There are many other causes like fungal, chronic pancreatitis, rheumatoid arthritis, or drug-induced pleural disease. The interesting case, that case has gram stain and culture sterile. No acid bacilli were found in the smear. Pleural fluid CB-NAT was negative. Cytological examination showed no malignancy. 48 after the admission, patient complained of, again, severe left-sided chest pain in the night. There was reduced breath sounds in the both infrascapular and infra-axillary area. ECG was performed, and this was the ECG. If you see carefully, lead 1 show this S1 and Q3 T3 pattern in this lead 3, and this characteristic S1 Q3 T3 pattern is a sign of acute or terminal, but it may be present in other cases also. The differential diagnosis could be acute pulmonary embolism in this case. And this shows this serial cardiac enzymes were normal. Chest radiography shows this repeated bilateral pleural effusion. And patient had a bout of cough associated with hemoptysis and fever up to 38. Possibility of PE was entertained. Therefore, D-dimer was ordered. It was positive. Patient was subjected to CTPA, and that showed filling defect in the both lower and upper lobar artery, right middle lobe, and lingular arterial artery branches consistent with the acute PE. There was no right ventricular dysfunction. And the CTPA showed filling defect in the both upper and left lower both pulmonary arteries, suggestive of bilateral pulmonary embolism. So this was the case of embolism causing the pleural effusion. A second case is 43-year-old woman, non-smoker, was referred to another clinic where she was treated by a doctor for fever, cough, and left chest pain. Chest X-ray showed moderate left pleural effusion. She reported no comorbidity. This is the pleural effusion in the left side. She underwent neither test nor thoracentesis. Doctor did not consider there as being necessary because effusion was small. She was given treatment with 500 milligram of levofloxacin for 2 weeks. After 2 weeks, chest X-ray showed improvement in the left pleural effusion. She had no fever, but chest pain persisted. 2 months later, the patient was well, without fever, slight thoracic chest pain on deep inspiration. Chest X-ray showed no parenchymal lesion, but the costophrenic angle was a bit obliterated. CT scan was normal. 3 months later, she presented with a swelling of right wrist without fever. MRI showed a typical feature of tenosynovitis. Rheumatic tests were all negative. She was treated with non-steroidal anti-inflammatory drugs. 4 months later, she presented with high fever, cough without sputum. Chest X-ray showed ill-defined nodular opacity in the upper lobes and no pleural effusion. And CT scan showed both this speculated nodules and branching focal ventrilobular opacity consistent with so-called tree-in-bud appearance in upper lobes. And this HIV were negative. A diagnostic fiber optic bronchoscopy was performed. No secretion in the tracheobronchial tube. This ball was performed in the upper left lobe. CB-NET was performed. It was negative, but culture was positive for Mycobacterium tuberculosis. In conclusion, the patient's clinical picture can be summarized as follows. At the beginning, left pleural effusion. 3 months later, right wrist tenosynovitis. After another 4 months, pulmonary tuberculosis. Failure to obtain a diagnosis of tubercular pleurisy results in spontaneous healing in 35% of the cases. Concerning the possibility of tuberculous etiology, pleural effusion, we believe that the subsequent clinical course and the positive response to quinolone are more than sufficient for us to suspect a TB effusion. But this drug should not have been given to this patient. A proper diagnosis is therefore essential for correct treatment. Tuberculous pleural effusion is one of the very common causes of this exudative pleural effusion. Pleural ADA level, I have already told you, interferon gamma should also be measured. Pleural fluid should also be sent for CB-NET. That is also positive in very small percentage. Needle biopsy and thoracoscopy should be ordered. So what is beyond this thoracentesis, thoracoscopy should be done in each and every cases of this undiagnosed pleural effusion. CB-NET in PA is positivity just around 32% or 20% there. In patients with negative CB-NET, tuberculous etiology cannot be ruled out with a degree of certainty. This AFB positive only in 10 to 20%, culture in 25 to 50%, diagnostic yield increases to 90% with addition of pleural biopsy, histology, and biopsy culture of AFB. Malignant pleural effusion, again, we have seen that thoracoscopy that gives the diagnosis of large number of this malignant pleural effusion. Any patient having symptoms of more than 1 month, fever not present because it is not febrile, hemoptysis if it is there, and CT chest shows features of malignancy. Lung cancer is the most common cause of malignancy. Second common is the breast cancer, and third highest will be the lymphoma and leukemia. So we should think about this. There are many diagnostic markers, 6 tumor markers are there, in which the carcinoembryonic antigen, carbohydrate antigen, and other antigens are there, but they are not very specific, although this some of the tumor marker will suggest the diagnosis. Basic pleural effusion are almost most commonly due to malignancy. Majority of malignant pleural effusion are symptomatic. Very low glucose in the absence of infusion is highly suggestive of rheumatoid arthritis. Rheumatoid arthritis or SLE, again, they are also some causes of undiagnosed pleural effusion. We should think about it. And rheumatoid arthritis is unlikely if the glucose level in the fluid is less than 29, more than 29. These are the causes of low sugar level. We should think about these low sugar causes of pleural effusion. SLE is also associated with bilateral pleural effusion. We should also think in this undiagnosed pleural effusion. The point beyond thoracentesis, thoracoscopy nowadays is advised and is done in majority of the cases where it is possible. And pleural biopsy is done. We can visualize this pleural surface for nodules or anything, and we can take up the biopsy. We can confirm by biopsy, culture, and other things also. This is the thoracoscopy. So this medical thoracoscopy, also known as pleuroscopy, today plays the gold standard to diagnose and manage the undiagnosed pleural effusion. It is a safe procedure, has a good diagnostic in the patients of undiagnosed pleural effusion. In malignant pleural effusion, thoracoscopy establishes diagnosis of more than 90% cases. Overall diagnostic yield of thoracoscopic pleural biopsy is 30 to 20 cases of undiagnosed pleural effusion. Bronchoscopy should also be done if a patient has got parenchymal infiltrates, hemoptysis is present. This massive pleural effusion is the cause of malignancy, and especially when the mediastinum is shifted toward the side of effusion, showing that there is obstructive endobronchial lesion. The open biopsy is sometimes done if the patient has got progressive undiagnosed pleural effusion. So what should be the approach? If any patient having the pleural effusion that is more than 1 centimeter height on lateral decubitus, or ultrasound confirms the diagnosis, CT confirms the diagnosis. If there is no sign of heart failure, do thoracentesis. Do measure this pleural fluid protein, LDH. If it is this transudate, see this systemic causes of pleural effusion, treat it. If it is exudate, or if it is the potential empyema, hemothorax and chylothorax, do the culture, do the hematocrit, do the triglycerides to confirm the chylothorax and the areas. And if it is exudate, do this ADA level, do the other tests also. If diagnosis is not there, if this do the CT scan, if the positive helical CT is positive for pulmonary emboli, confirmed by CTPA. If no diagnosis is still, go for the bronchoscopy. If hemoptysis, atelectasis, and pulmonary infiltration are there, and if not, do this thoracoscopy. Take the biopsy, confirm the diagnosis either by tuberculosis or the malignancy or other tissues. And if the patient is improving, observe it. And so, presence of transudative pleural effusion indicates existence of systemic disease. The exudative pleural effusion is maybe this TB and malignancy are two commonest cause. TB effusion is caused by equal frequency by primary and reactivated TB. Hemothorax may present at hematocrit is more than 20%. The approach of this undiagnosed pleural effusion should be that take the proper history, classify it whether transudate or exudate. If the diagnosis is not clear by the different tests, go for the thoracoscopy and confirm the undiagnosed cases of this pleural effusion. Thank you very much.
Thank you, sir, for a wonderful presentation. Sir, I have one question, sir.
Yes, sir.
Sir, in the second case, where the pleural effusion had disappeared, only tenosynovitis was present in the wrist. Second clinical case, sir.
Yes, sir.
Sir, in the second clinical case, when the patient was given levofloxacin, the pleural effusion had disappeared.
Yes, sir.
And after 2 months, the patient presented only with tenosynovitis of the right wrist.
Yes, sir.
Sir, at that time, suppose patient comes only with the swelling, with all ANA or rheumatoid factor, everything negative. What could we have suspected, sir?
At that time, also that the lesion was due to tuberculosis. That tenosynovitis is, that rheumatic causes, rheumatic involvement of tuberculosis is there. And it has been seen that if the small pleural effusion is there, or pleural effusion is there, if it is not treated at the first step, it can present either with the extrapulmonary tuberculosis in the different organ, even this joints or bones, etc. And later on, it may present in the lung itself. And the more serious cases have been seen. So the first step, my message was that in this case, why not it was diagnosed and treated first? And then after 3 months, it presented with the tenosynovitis, tuberculous tenosynovitis, it was there. At that time also, he was not, the patient was not treated. But once there was a pulmonary lesion, and then the diagnosis was done and the patient was treated.
Dr. TP Singh, once the patient has rheumatic pleural effusion followed by any rheumatic manifestation, the diagnosis comes collagen group of diseases, SLE and other things. But
Yes.
it is because levofloxacin acts as anti-tubercular. So it should not be used. You should.
That was done by the primary health center doctor.
That's what I'm saying. And falsely the patient was improved.
Sir.
And it has got anti-tubercular property. But what is the importance of tenosynovitis? That presence of tenosynovitis, you may correlate with pleural effusion, but both together, if you see, mostly they occur in collagen group of diseases, SLE and other things, rheumatoid arthritis. But it is a third when you had, after 4 months, picture in the lung, then finally it came that it could be tubercular.
So, yes, sir, first 2 steps, it was not diagnosed. It was outside the medical college.
Oh,
it was outside the medical college, not here. Once the patient has the pulmonary lesion again,
he came in the third stage. Oh.
Yeah, yes, sir.
Now, DP Singh, we are getting in our part here, amoebic liver abscess is one of the cause, rupture of amoebic liver abscess or sympathetic liver abscess, one of the cause of pleural effusion. Only day before yesterday, patient came with the liver abscess. He had rupture in the pleura and 800 cc we aspirated. So, in our part, in this season, we are getting liver abscess very common in July, August, September, and associated with pleural effusion.
Sir, it may present with the 2 ways. There may be sympathetic effusion.
Yes, and rupture.
Not pus. And the second will be that it will rupture in the lung,
yeah.
And then there will be a pus empyema, this lung abscess is there. Sympathetic effusion is again confused with tuberculosis, sir.
Yes.
I have seen one of my doctor being treated for the anti-tuberculosis drugs, and after when it was stopped, it was liver abscess was there in the liver, and it was given the anti-amoebic treatment, and that effusion vanished.
Yes.
That was sympathetic.
Yes.
Sir.
Thank you, sir. Thank you, sir, for such a wonderful presentation.
We have to close this.
Sir, we'll close the session now, sir.
Thank you. Once again, thanks to organizer and especially Dr. Jan Panda for giving us opportunity. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, Chairman.
Thank you, sir. Diabetic Thyroid Care and Research Center at Jabalpur. He is the President, Jabalpur Endocrine Society, Organizing Secretary, RSSDI MP Chapter 2020, Vice President, RSSDI MP Chapter, Member of the AACE, Endocrine Society of India, API, IMA, RSSDI, ITS, Diabetic India, IACM, received many awards and recognitions, received RSSDI Fellowship Award for the year 2020, and received the Best Diabetic Awareness Initiative Award at RSSDI 2014 Diabetes of India. Today, he will be enlightening us on the diagnostic dilemma in diabetes, a case-based approach. Sir, can you start, sir?
Yeah, thanks a lot to the organizers for inviting me here, and especially Jayant for inviting me to deliver a very important talk on this important topic, that is the diagnostic dilemma in the diabetes. Because in our clinic, the patients are coming with the presentations of diabetes at the young age, and we are confused that how we should move on. So Apicon Odisha 2022, congratulations to you all. And we will be unlocking the diagnostic dilemma in the diabetes. In the coming few minutes of journey, I will be taking you through the cases like 9-year-old boy coming to your clinic with diabetes, 12-year-old girl, 15-year-old, 20-year-old man, and 32-year-old man. So all these cases will be unlocked, and gradually we will be learning that how to diagnose and treat the patients who are coming at young age and when we are confused. So case 1 is a simple 10-year-old girl coming to your clinic with 3 Ps: abdominal pain, tiredness, weakness, and loss of weight and burning micturition. Sugars are very high. HbA1c is 10%. Fasting PP is 209 and 378. No family history. On examination, she was having very weight loss and having BMI of 12.5 kg. No markers of insulin resistance. Severe dehydration was present. What next you will do? So we have ordered a ketone test and it was positive. So she was having ketonuria. Blood ketone levels were also high and triglycerides were high. So this patient was ordered the C-peptide levels and it was very low. It is 0.2 and normal range is more than 0.9. So the patient was having absent beta cell function. GAD antibody was positive, as we have suspected the diagnosis of type 1 diabetes. So this patient was a type 1 diabetic with ketosis. She was managed as on the lines of ketoacidosis, and the dehydration was corrected with IV saline. Infusion pump was started on insulin infusion, and she gradually improved and shifted to multiple daily injections of basal bolus therapy, and A1C came down to 7.4% and she was followed up. So my message is that in the young patient, all patients are not type 1, but we will see the cases that how we can unlock this dilemma. The diagnostic sensitivity and specificity of autoantibodies for type 1 diabetes are very good. The insulin autoantibody and GAD antibody, IA2 antibody are having sensitivity and specificity of nearly 99%. And the type 1 diabetes develops in an environmental trigger in the genetically predisposed patient, leads to autoimmune dysfunction, and ultimately the beta cell dysfunction is there. And in type 1 diabetes also, there is a pre-diabetes phase of immunological abnormalities in a genetically predisposed person, and gradually they develop clinical type 1 diabetes. But in few very rare cases, there can be some weeks or months of honeymoon period where they can have little secretion of insulin, and then comes the chronic phase. So my dear friends, you have to suspect a type 1 diabetic patient, young, coming to your clinic with high sugars, 3 Ps, acidosis or ketosis, and it is easy to diagnose these patients. But my second case, a 13-year-old girl detected to have diabetes since 8 months, and she was having BMI of 29 kg per meter square, and she was started on basal bolus therapy, suspecting the age of 13 years, she was suspected as a type 1 diabetic. But despite of starting the insulin, she was not controlled and she was asymptomatic, but sugars were very high. A1C was coming still 9.2%. But she, when she was gradually taken the history, the strong family history of diabetes was there. Ketonuria was absent in this case. So what do you suspect? Young girl, again high sugars, not getting controlled on insulin. So the pedigree charting was done, and the patient is a diabetic. Mother, father are diabetic. Paternal mother, father are diabetic. So there is a strong family history of diabetes in this patient, but on the both the sides. So in this patient, the significant feature was BMI was 27, A1C was high, triglycerides were high, no evidence of any micro or macroangiopathy. Abdominal X-ray was normal, but acanthosis nigricans was present on the neck, and she was obese. And what we will suspect, we will do C-peptide levels. It was good and preserved, and GAD antibody was negative. So our diagnosis was confirmed as a type 2 diabetes, early onset. And this group of patients, or this set of patients, we are seeing day by day in our clinics because of the junk food and the non-movement of the young boys or girls. They are not playing, they are seeing the mobile and TVs, and that's why the weight is gained, and they are developing the type 2 diabetes at a young age. So we should suspect she was off insulin, managed on diet, exercise, started on glimepiride, metformin. A1C came down gradually to 5.7, glimepiride was withdrawn, and metformin continued. So suspect any type 2 diabetic patient in a young patient coming to your clinic, which are having strong family history, signs of insulin resistance, obesity or acanthosis nigricans with preserved beta cell function. So C-peptide and GAD antibody can help a lot. Now moving to the third case, again a young girl. She is having diabetes since 3 years on basal bolus therapy and presented with recurrent UTI and vaginitis. She has a strong family history of diabetes in mother, nani, mausi, and elder sister. So we have a strong family history in the maternal side, that is mother, nani, mausi, and elder sisters are diabetic. So what do you suspect or next step? Pedigree charting is very important in these cases. This is a patient, this is mother, mother, sister, nani, all are diabetic. So on examination, she was having BMI of 20 with no other abnormalities. What next investigation you will advise? In this case, family history strongly positive, and she is on basal bolus therapy but still having recurrent vaginitis. So the patient was having no evidence of pancreatic calcification. C-peptide was 1.4. So fairly good beta cell function was seen in this patient after investigation. So this was a case of monogenic diabetes, that is moody, and you should suspect. And I have diagnosed in my clinic 3 cases, and they are doing well on sulfonylureas. So differences between moody and early onset type 2 diabetes is very important. The moody is non-obese usually. Acanthosis is uncommon. 3 generation in the one parent side, that is mother side se hoga ya fir father side se. Only secretory defect is there in insulin, seen in all can be seen in all population, responds better to sulfonylureas. On the other side, the early onset type 2 diabetes, which we are seeing in the young age, the patients are obese and overweight. Acanthosis can be seen. Both parents could be affected. The signs of resistance are also there. Insulin resistance is common in these patients, usually seen in population with high prevalence of diabetes like India, China, and responds better to metformin. So this is simple gradation which you should know. The maturity of onset of diabetes is a monogenic form with a single mutation, and genetic analysis is needed. And all the members of this family were having the HNF1 alpha gene when the genetic analysis was done. They were having MODY3. The genetic screening is needed to confirm these patients. After shifting from the basal bolus therapy to the sulfonylurea metformin, the A1C came down to from 11.9 to 7%, and she was off insulin, and metformin was also gradually withdrawn. So monogenic diabetes, the clinical features by Sal and Fajans, that the diagnostic criteria you should keep in mind that it is a mutation in single gene, usually non-obese, age is less than 25 years usually, autosomal dominant inheritance involving 3 generations and no ketosis, do not need insulin initially, but later may become insulin dependent in MODY1 and MODY3. Isolated fasting, mild hyperglycemia is seen in MODY2. They don't require any treatment. The diabetes with renal cyst and renal agenesis, that is Arquette syndrome, it is MODY5. So this is simple diagnostic criteria. The genetic causes of MODY, there are various types: 1 alpha, 1 beta, HNF 1 alpha, 4 alpha, 1 beta, and MODY2 is GK mutation and other types. So GCK mutation, glucokinase mutation, that is MODY2 does not require any treatment, because in various studies they have proven that untreated for 50 years they have no significant micro or macrovascular complications, and mild fasting hyperglycemia is there not much. So to summarize, in this monogenic diabetes, single gene mutation, autosomal dominant inheritance, and age is less than 25 years. Moving on to the 4th case, the patient came to the clinic, 20-year-old boy, since 6 months diabetic and 10 kg weight loss, oily stools, abdominal pain, no history of alcohol or diabetes. He was put on triple drug therapy because of very high sugar, 12.8% HbA1c. Fasting PP was very high. He was on metformin, glimepiride, and pioglitazone, but still his A1C was very high. So what should we do? The patient was having low BMI, 18, and ECG was normal. C-peptide was poor beta cell function, 0.7 picomole per ml. So this is a type 1, type 2, or any other variety, because it is mimicking the type 1, poor beta cell function, BMI is very low, but the ketone is absent. What next you will do? So in this case, we suspected the other causes of pancreatic diabetes, that is abdominal X-ray showing the multiple calculi at the level of T12 and L1. So this was a case of FCPD. fibrocalcific pancreatic diabetes, put on basal bolus therapy, pancreatic enzymes were started, and after 3 months, he was asymptomatic and A1C came down to 7.8%. So such a drastic improvement in this patient's life, because with the correct diagnosis, with the correct treatment, you can save the life of a patient. So this, he came like this, very thin and lean, and now he's very having good build with the basal bolus therapy. So uncommon form of pancreatic diabetes found in certain parts of India, and it is usually from tropical country. Evidence of chronic pancreatitis should be present. The pancreatic calculi in plain X-ray abdomen was seen. Recurrent abdominal pain was there, and abdominal pancreatic function tests were there. So absence of other causes of pancreatitis should be ruled out, that is alcoholism and hepatobiliary disease, to diagnose the FCPD. So you can see that stones, pancreatic stones in the CT, in the X-ray. So BMI less than 18, history of oily stools, recurrent pain, absence of ketosis in spite of very high glucose levels, severe diabetes with fasting of more than 200. So this is a case of FCPD. And the most commonly found in Kerala and Tamil Nadu, and etiology is still unknown, but they have a risk of pancreatic progressing to pancreatic carcinoma. The case 5, again, a young boy, a young man coming to your clinic with high glucose levels, 9.9%, fasting PP high, and on examination, he was having acanthosis also, GAD antibody and ICA antibody was also positive. So we are again confused. He is having features of both type 2 and type 1 diabetes. So what is your diagnosis? So this patient coming to your clinic, acanthosis, insulin resistance is present, but the signs of antibodies was positive. So this is a LADA, mix of type 1 and type 2. So latent autoimmune diabetes of adult, it is type 1 diabetes which is presenting late. So positive for at least one of the autoantibodies associated with type 1 diabetes, age more than 30, free from insulin for the first 6 months after diagnosis. And these patients usually are lean and have poor beta cell function as assessed by C-peptide, and they require insulin treatment much earlier in the course of disease than the type 2. So they begin with the features of type 2, but in the last, they require insulin very early. So diabetes with phenotypic type 2 and immunologically type 1 with autoantibodies, it is LADA. So LADA is also known as hybrid type 1, 1.5 or double diabetes. So all these names are given to LADA. So LADA is a hybrid of type 1 and type 2, beginning with type 2 and ending with the type 1. So they can have acanthosis. So initially patients of LADA are controlled on metformin or sulfonylurea, and gradually they require insulin because they have very low beta cell reserve. So coming to the end, that how you diagnose these patients and how you unlock the dilemma, it is very easy. Please take the pic of this chart. Patient young coming to your clinic, if they are having the family history positive, take the proper pedigree chart, 3-generation positive on the one side, ketonuria absent, fair C-peptide, responds to sulfonylurea with no signs of insulin resistance, it is moody. If the 3-generation history is absent, ketonuria is absent, C-peptide is good, and response to metformin and acanthosis or insulin resistance signs are present, it is early onset type 2 diabetes. Now on the coming on the next part, the family history is negative, but ketonuria is positive. It is C-peptide is totally absent. It is type 1 diabetes. Type 1 can be categorized as an autoantibody positive or negative. In some cases, they may be negative with idiopathic type 1, and most commonly they are positive with autoantibodies. It is autoimmune type 1. C-peptide is poor. X-ray showing the pancreatic calculi. It is FCPD. So my dear friends, we are unlocking the dilemma today. We begin with cases like 9-year-old boy, 12-year-old girl, 15, 20, 32-year-old with high sugars coming to your clinic. And we were starting insulin previously in all these patients. But now due to the diagnostic criteria available, so this boy was a type 1. 12-year-old girl was type 2 early onset because of the junk food and non-exercising. This 15-year-old girl was moody because of the family history in the 3 generations on her mother side. This boy was having the FCPD and severe weight loss and gradually improved a lot. And this patient was having LADA because initially he was responding to the metformin sulfonylurea, but gradually within 6 months to 1 year, he required insulin. So I hope I unlocked the dilemma today, and I hope the justice have been made, and we are doing the wrong things in our clinic. I hope we should not do from today, because it is very easy if you give the time to the patient. If the young patient coming to your clinic, and if you take the proper history, pedigree charting, family history, and clinically only you can diagnose these patients. So thanks a lot for patient hearing. Once again, thanks Jan for calling me to the Apicon Odisha 2022. Thank you.
Thank you, sir, for your excellent talk. All cases were very interesting. There is no question in the question box, so can move to the next topic.
Thank you. Thank you. Thanks a lot.
The next speaker are Dr. Vayesh and Raju, and then after Dr. Ashok Taneja. Both are not available. Then Dr. Ashok Chaudhary will be there. So we move to the Ashok.
Now we welcome Dr. Ashok Chaudhary. Am I audible?
Audible.
Okay. So he was my junior actually when I was doing my PG. He did his MBBS over here, MD from SCB now and DM. He's a senior consultant, transplant hepatology and clinical lead hepatology and gastroenterology. Dharmasala Narayan Super Specialty Hospital, Delhi. Narayan Super Specialty Hospital, Gurgaon. Today he will be talking about DCLD management, what's new. So can we start?
Yes, sir.
Okay.
At the outset, I want to thank the whole team, AP Odisha chapter. So, as rightly said, I feel privileged to be present in my home state and in my own state annual conferences. So, so the topic today is the DCLD, that is decompensated liver disease, and itself whole is a book. So I will try my best to justify the topic in stipulated time. So how to go for the management. So just I'll briefly talk on the important areas. I think my slides are visible now. Yeah. So nothing to disclose. So I will in follow-up periods will go through these areas. So liver disease spectrum is from a normal liver to fibrosis to cirrhosis. Once the cirrhosis happens, it can be a compensated phase, it can be decompensated, and it can be end-stage liver disease. So DCLD term is used for both decompensated as well as the end-stage liver disease patients. So when we talk of they have a DCLD, there is two components. One is portal hypotension, another is the liver synthetic function. So how this happens, you can see whenever any insult happens to a chronic liver disease, if it is acute, they develop ACLF as the first presentation. Over the time, they develop acute decompensation or ACLF. And these episodes may get recovered and or this progress to decompensated cirrhosis. And as we know, they get repeated insults, maybe alcohol, maybe drugs, maybe infections, or some acute insult. Then they progress to either they develop an acute decompensation. Over the time, they get recovered, or they remain same, that is end-stage liver disease. So this is the whole spectrum of a chronic liver disease and its response to acute insult at each point of time. Here, one syndrome complex comes, that is ACLF. ACLF is that is acute or chronic liver failure. It is similarly the acute insult because of these various causes we have mentioned here in a background of chronic liver disease with or without cirrhosis. And after this acute insults, they develop jaundice, coagulopathy, ascites, or under hepatic encephalopathy. So this is a syndrome complex of having jaundice, coagulopathy, Ascites or hepatic encephalopathy develop in a period of 4 weeks from the acute insult in a background of chronic liver disease with or without cirrhosis. And this is the most one of these serious condition. However, 50% may recover with adequate management without need of a transplant. This is like ALF, where ALF the background liver is normal, whereas in SLF the background liver is bad. So what happens when a person of CLD gets liver injury? There is a window period, and over the time they develop gradually the liver failure, and at the same time they develop the extrahepatic organ failures. And this is a syndrome complex where the gut dysbiosis happens, there is genetic predisposition, and there is inflammation, and over the time this systemic inflammatory response becomes complementary anti-inflammatory response syndrome, that is CARS. Then you develop immunoparalysis, sepsis, and the shock. So this is the briefly outline about how a liver failure or DCLD is behaving. So now we'll go to individual complications. You can see in a complicated cirrhosis, you can get the components of portal hypertension, get the components of synthetic function. These are the two parameters to define a cirrhosis. So cirrhosis or chronic liver disease has portal hypertension manifestations like varicose bleed, ascites, hepatic encephalopathy, hepatopulmonary syndrome, portopulmonary hypertension. And the synthetic components are jaundice, coagulopathy, ascites and hepatic encephalopathy happens in both the groups, hepatorenal syndrome and SBP, that is spontaneous bacterial peritonitis. So just as we are going to discuss only briefly how the management changed over the time, I'll just go to the most common complication, that is ascites. So everybody aware, the ascites needs approach from history to examination to investigations. Just I want to give a little bit of brief history. If it is acute, it can be SBOT or cardiac. If it is painless or painful, if it's painful, then it will be malignancy, SBP or acute onset. If it's rapidly failing, to consider malignancy. And if the eye and face, I think everybody knows as internal medicine, I'm not going to discuss in this. So these are the few close to this. Most important in patients of cirrhosis is that we have to think of ascites in three terms. Is it a new onset, that is the fast time, or it develops worsening over time, that is recent worsening, or it is refractory, that means it's not responding to standard regimen of diuretics. So these three will make a decision how to go for. So when you know the ascites in a cirrhosis, it can be uncomplicated or complicated. So uncomplicated ascites is the simply a ascites which we know to be graded as grade 1 to 3, and the treatment is most importantly the sodium restriction, that in the salt, and most important another one, the most commonly people advise the bed rest, which is not needed. A liver cirrhosis patient needs maximum mobilization, maximum physiotherapy, and maximum exercise. So most important is to consider the diuretics. So diuretics, as everybody aware, the most common should be considered is the mineral corticoid, that is spironolactone. Then we have to add other groups, particularly lobe diuretics. And when we are adding diuretics, we have to take a checklist. The checklist means your patient has having GI bleed recently, having AKI, having hepatic encephalopathy, hyponatremia, or there is variation in laboratory parameters in relation to sodium and potassium. So dear friends, before considering hepatic start of a diuretics, this checklist should be, you have to follow religiously, and diuretics should be temporarily held in patients who are having hepatic encephalopathy, either persistent or more frequent. Then when we are giving diuretics, we have to know the response. The response is defined weekly basis. That means the weight reduction of 0.5 kg per day without edema. If patient is having edema, it should be 1 kg per day. And then next important is that you have to think of monitoring the laboratory parameters weekly. When we are escalating the dose of a diuretic for a cirrhosis patient, hyponatremia, AKI, hepatic encephalopathy, or muscle cramps. These are the four things we have to remember. And if it is hyperkalemia or hypokalemia, we have to adjust accordingly. And albumin is a good need for these patients. When these persons are not responding to the medications, have a tense ascites, we consider this as the grade 3 ascites, and we need a ascites to be drained, and that draining is need to be supplemented by albumin. So the albumin should be started pre, and then the ascites should be tapped, and during ascites tapping, we define as large volume is more than 5 liters. And when we are going for the 5 liters, we have to consider the help of albumin. This is one. Most important thing that what we do that in patients of cirrhosis, we don't know what to avoid. So here just want to highlight that NSAID group of drugs should be completely avoided at any condition. Try to consider other groups if anything pain or managements are there. Aminoglycosides should be very much discouraged. Contrast should be needed if we are going for a therapy that is going to change the management. Otherwise, we should avoid the contrast for the CT scan. If we are having hyperglycemia, hyperkalemia, then considered to be changed. So this is the management of the ascites uncomplicated. So then we come to the complicated ascites. Complicated ascites is either it become refractory, it develops SBP, or most oftenly the ascites associated with the hyponatremia, or the persons are having sarcopenia. So this is considered as the complicated ascites. So if, as we discussed, the refractory ascites is either diuretic intractable or diuretic intolerant. Diuretic intractable is that the dose is not responding, or diuretic intractable as this develop complications like hepatic encephalopathy, renal impairment, hyponatremia, hyper or hypokalemia, or the muscle cramp. That means your diuretic, he is not tolerating. So that means it is intolerant. So this group of people are called the refractory ascites. So refractory ascites, we need to think of two things. Albumin should be given religiously. Beta blockers should be considered, depend case to case basis, but try to avoid the beta blockers if possible. If we are going for the beta blockers, definitely, then we should consider non-selective beta, particularly propranolol, not the carvedilol, which is used otherwise. And to take care of these patients who are on beta blockers, if you are thinking of stopping this refractory ascites related worsening, then endoscopic band ligation should be considered as the protocol. Hence, we can prevent the bleed also. Then another important is that this group of patients will become refractory. We have to consider either TIPS or the transplant. When transplant is needed, will come later. If the patient is a potential candidate to go for, if his child B, male score is below 17, then they should be considered for the TIPS. So just to summarize, in a case of a refractory ascites, we have the basket of liver transplant is definitely. TIPS is for selected group, that is child B or male score is below 17. Otherwise, what you can do at your clinic is liver large volume paracentesis, to be supplemented diuretics, to be supplemented albumin, midodrine and valproatins I have not considered, and few encouraging therapies are coming up, that alpha pump, that is abdominal drainage of ascitic fluid into the urinary bladder through a pump. And whenever a person comes to you having worsening of ascites, we need to evaluate for his sarcopenia. We have to see for the hepatic encephalopathy frequency, and they often deteriorate because of development of SCC or portal vein thrombosis. And if these people are having frequent hyponatremia, then we have to think of, and obviously poor performance status should be. So this is, dear friends, for ascites, the treatment should be considered phase wise. Initially, the LVP with the medical support with the gadgets I have shown here. TIPS could be considered in a selective group of patients, and majority may need a liver transplant. And when we are going before, we need evaluation for this group. Then important is the next is the SBP. SBP is the infection of the ascitic fluid in absence of any secondary cause. It is typically related to the gut modulation and the cirrhosis related immunocompromise. So any person of cirrhosis coming with a GI bleed with ascites, if they have a shock, having systemic inflammations, any GI symptoms, diarrhea, constipation, pain abdomen should be considered. Unexplained hepatic encephalopathy in a cirrhotic. Any person develop worsening of liver renal function, if they have ascites, then you have to keep a very low threshold just to tap the ascitic fluid to diagnose SBP. And SBP prevention, the parameters has over the time changed. It is now considered to be the ceftriaxone with albumin is the best drug, and over the time cephalosporin has been considered, and recently it is called as difficult to treat SBP, where we need further antibiotics. Here I want to highlight, in a patient of cirrhosis to ascites, albumin is the cornerstone of management. It helps in ascites mobilization. It prevents SBP and hepatorenal syndrome. improves the cardiac contractility to mobilize the fluids. It has anti-inflammatory modulations. It prevents or reduces the muscle cramps. And if you are going for the surgery to prevent post decompensation, it is needed. So, dear friends, albumin has a multi-potential role rather than oncotic property. So, oncotic property is only one part, whereas other parameters are helped also by albumin use. So, albumin in cirrhosis established indication is paracentesis into circulatory dysfunction that we have discussed, that volume expansion for SBP and for HRS. And now it is upcoming for hyponatremia management, for hepatic encephalopathy and non-SBP infections too. And gradually the emerging indications are coming up for the acute decompensation and ACLF. So albumin is not only for a mobilization or targeting the albumin level, it is to the prevent complications and support. So as we discuss SBP, the SBP is once infected person, the chance of having recurrence is close to 50%. Hence, any person of SBP should be considered for the liver transplant at the earliest. The SBP prophylaxis, as you know, everybody, the norfloxacin is the standard drug, and this is we consider secondary prophylaxis once the SBP happened. However, to prevent SBP, the primary prophylaxis can be considered in patients with a child score more than 9, bilirubin more than 3, those having hyponatremia, those having frequently AKI, and when you have done acidic fluid tapping, if it acidic fluid protein is less than 1.5. So these are the recommendations by the European and American societies. And any person comes to with acute GI bleed, they should be considered for the primary prophylaxis. So these are the groups where we need primary prophylaxis. Otherwise, once a person develops SBP, he needs lifetime secondary prophylaxis or till the transplant happens. So this is the prophylaxis. So drugs, as we discussed, is the first is the norfloxacin is the standard. However, now rifaximin is considered to be a newer drug because systemic absorption is less, chance of having bacterial infection resistance is less, and it is upcoming. Beta blockers also helps to some extent, and probiotics are now coming up as a helpful in preventing this toxin. So, dear friends, we have completed the most common part, that is ascites in a DCLD. The next we consider hepatic encephalopathy. Hepatic encephalopathy is any level of confusion, altered level of consciousness, and associated with liver failure. So, treatment, I think everybody know. The most important one to highlight that to find a precipitant. Most of the time, hepatic encephalopathy is because of constipation, electrolyte imbalances, varicella, or infections. The most important to change our mind is protein restriction. In case of hepatic encephalopathy, there is no need of protein restriction. That is a Elders dilemma, which is considered to avoid the ammonia, we need to reduce protein. So now it is not needed at all. Only condition where you consider is the refractory encephalopathy. That means once the patient is admitted with encephalopathy, is not improving beyond 7 days, then you can think of restrict the protein, provided your ammonia value is high. Otherwise, if it's normal ammonia, then is no need of protein restrictions. And the treatment is purging as the first and the foremost treatment. Rifaximin is to be definitely to be given as a primary therapy as well as the follow-up therapy. And here we miss most of the, as an internist, I request you to consider supplementing the zinc. Zinc is more important. Lola has been often advised to the patients on a regular long term. This should be discouraged because Lola causes counter ammonia production and its role is established only in ALF. Hence, cirrhosis patient, it should be used very occasional or try to avoid. Once hepatic encephalopathy, it qualifies the criteria for the transplant, there should be restricted. As a physician, as a super specialty, we have a tabular vision. We always think of hepatic encephalopathy, but at the same time, we have to think of mimics. A person of cirrhosis if coming up from an altered syndrome, he or she is not immune from having CVA, he is not having immune to the intracranial bleed, he is not immune from other infections or other convulsions. So these are the parameters what we have to think also in a patients of hepatic encephalopathy. And we have already discussed about the treatments. I'm not going to detail. Now, hepatic encephalopathy, if it is single episode, justifies for a transplant evaluation. If it is recurrent, definitely. If it is persistent, also definitely. And important, I'm not to comment because lack of time, is the minimal hepatic encephalopathy. That means persons are of hepatic encephalopathy which is not overt, it is minimal. These are the groups where we need to consider. So, dear friends, we have completed the second important one, that is hepatic encephalopathy. Then third is the varicose bleed. Varicose bleed is one of the emergency in the case of cirrhosis practice. It can be esophageal varices, it can be gastric varices, it can be portal hypertension gastropathy, or it may be ecto varices at other sites. The treatment for this is propanol or carvedilol. Target is your pulse rate should be up to 55. You can increase the dose till the pulse rate goes below 55. Blood pressure target in cirrhosis is 100/60. I want to highlight a person of cirrhosis, portal hypertension treatment is not on dose based, it is the response based. That means this person should be considered for regular BP and pulse monitoring. If pulse is below 55 or BP going down below 100/60, then that is the optimum dose. For propanol, it is 160 milligram. It is for carvedilol, it is 25 milligram. These two drugs are available in India. Then, if not responding, or if large varices and poor patient compliance you are expecting, or the person is poor to follow up, then you can consider the banding or the ligation. That is primary prophylaxis. Secondary prophylaxis is any person once develop varicose bleed, we have to treat with the drugs as well as endotherapy. So, secondary prophylaxis for a varicose bleed is both endotherapy with endoscopy according to varices. In addition, the targets as we discussed for the drugs. When a person comes to the acute varicose bleed, it is a medical emergency. We need to have to treat it at a flight of speed, and the treatment is mostly immediate endoscopy. Before endoscopy, you need to assess the person for his severity of bleed, assess his hypovolemia, and then we have to address the airway, breathing and circulation first before going for the endoscopy. So here these persons need a large bore needle, crystallite till you get a blood, then target hemoglobin should be kept around 7, and at the same time we have to consider if you need to correct any coagulopathy. So this is the next important is the varicose bleed we covered. Then dear friends, we have come to the fear, everyone fears of the coagulation. Liver disease is not a coagulation failure disease. It is a balance. It is called as a rebalance situation where the hypocoagulous state is balanced with hypercoagulous state. So first we'll go for the hypocoagulous state. When a person comes to you, you have a low platelet, you have a high INR, appetite is prolonged, but these all parameters are never a gold standard for defining the procoagulant risk. Now it is coming up is the viscoelastic testing, that is ROTEM or TEC, which are now considered to be the good parameter for the global coagulation assessment. However, they are limited by their cost as well as the availability. The most important thing that in a patient of DCLD, we have to identify the person for the procedure whether they are at the high risk of bleed or no. So you can see here the high risk procedures are the major surgeries, intermediate are the senior surgeries, but most of the things what we do as an internist, as a hepatologist, as a gastroenterologist is paracentesis, thoracentesis, dental extraction, endoscopy procedure, cardiac or central end placement. These are possibly low risk procedures where platelet INR is not going to help. It is rather you can see presence of sepsis, renal failure or AKI may risk of post-procedure bleed. That is important. Then how to treat these patients? You can see the person risk for bleed is depend upon his general conditions. If it is sepsis related, high chance of bleed. If it is emergency, then the chance of bleed. If it's non-varicose mucosal bleed, then chance is more. The less is on the varicose bleed and less is on 10%. And how to treat? We have lot of products with us, that is plasma, platelets, cryo, factor VIII, and prothrombin complex concentrates. Here I want to highlight the most probably patients think that we will treat INR by giving FFP. In a cirrhosis patients, FFP should be avoided. It causes overload, trally, and even whole blood bank you adjust with giving plasma, the INR is not going to improve. So treatment is only when there is active bleeding, when you document that their factor is deficient, if it is drug related, and if you want to reverse the warfarin therapy. So dear friends, remember that cirrhosis should not be treated depending upon only the INR value. Similar is also for the platelets. If we give platelets, it is going to cause unnecessary allo immunization, and the treatment response is not going to happen. Once we treat, if it is below 20,000 for any procedure, or the patient is having ongoing bleeding, or you are having massive transfusion related consumption coagulopathy, or when it's drug-induced thrombocytopenia. However, now drugs has come up like Eltrompac to now newer drugs also, where you can tide over the crisis if you're going for a selective procedure by giving a short term of the drugs. So now these two drugs are coming up which are having less side effects. I'm not going to detail. Then cryo, everybody knows it is just to be given. Factoid has not been recommended. Most important now it is coming as the prothrombin complex concentrates. The prothrombin complex concentrate is a pooled plasma product which can be given irrespective of the blood group. It corrects the INR on the faster way, and this is indicated only for the coagulation related things. And now it is the need of the future in persons of the cirrhosis. So just to remember to highlight that in a patient of cirrhosis, don't think of platelet INR. Stratify if you are going for intervention. Transfusion is only needed if is active bleeding, or you need to antagonize the vitamin K antagonist related bleed. If possibility of PCC is there, you have to consider. SDPC should be considered rather than over the random donor platelets. Cryo should be considered over the FFPs. And we should remember that we should never think of correcting INR. We should not run behind platelets as a number. Prophylactic coagulation that the patient may bleed, it should be deferred. FFP routine use should be discouraged. And Eltrompac also not to begin for a long term except for the short term. As similarly we thought of that cirrhosis is a hypocoagulable, also cirrhosis is also hypercoagulable. There is a prothrombotic risk. In a cirrhosis, the thrombosis can be splanching, that is portal vein or splenoportal axis, or hepatic vein, that is SBOTO. It can be cystic, that is deep vein thrombosis, or cavernous venous thrombosis can happen. And these are the symptoms only when it is acute thrombosis, or when it is a recent thrombosis, or when it is a chronic thrombosis progressive. So otherwise chronic thrombosis is not symptomatic. Any person to be treated with a coagulation, we need to consider the major stratifications. I'm not going here. So cirrhosis treatment is needed for portal vein thrombosis if it is acute, recent and symptomatic, or it is progressive, or a patient is waiting for the transplant where we need to treat. The treatment available both with the low molecular heparin and vitamin K antagonist. Dear, I want to say here that liver disease is not thing that it is always bleeding tendency. We can give them anticoagulations when there is justifiable indications. And now the direct acting anticoagulation has come up. I want to highlight the dabigatran is relatively liver friendly and it can be given comfortably. So these are the groups of drugs should be considered child A and B, not child C. And as you thought of the fear, only thing you have to go in a patient to give anticoagulation is to ban the large varices, and if platelets below 50 should be considered to be avoided. So this is an algorithm proposed by me. A person with acute or recent portal vein thrombosis should be treated. If it is a chronic portal vein thrombus, if it is symptomatic or progressive, or it is asthmatic progressive, should be treated. In a cirrhosis, it is not to be considered in all cases. The treatment should be for minimum 1 year. Then to define non-responder, if they have a coagulation result, they should be considered till lifelong. Otherwise, they should be considered till transplant. So remember, cirrhosis can be treated. So in a case of cirrhosis, the hypolysate state is because of portal vein thrombosis or SBOTO should be considered. Pretest probability should be considered. Treat if it is acute, recent, symptomatic, or before transplant. Prothrombotic testing should be considered if it has a portal vein thrombosis. Asymptomatic should not be treated. Antiplatelet drugs or aspirin has no role. It should not be considered for all the cases to be treated in absence symptoms. So this is one of the next common important thing. Then next important is the hepatocellular carcinoma. You can see this graph, the SCC is going, and Asia is the capital for this SCC burden in the world, and hopefully India also. And you can see this graph, the persons of people having SCC, if you go through, the NFLD has the highest risk, as you can see, and India is at the highest risk. So any person developing SCC, we thought it is hepatitis B related, but there is a change in demography. Now peoples of NFLD are going to have a SCC. That can be also with SCC, without cirrhosis or with cirrhosis. And India, the number is highest, close to 35%. That means a cirrhosis or a non-cirrhotic SCC diagnosed in a patient of chronic liver disease, the NAS is the major common cause and it is growing rapidly over the time. And this is related to the lifestyle. This is related to the secondary interventions, multiple risk factors. I'm not going. Just want to highlight that we should consider testing for all patients with the ultrasound or if possible AFP, not alone. So ultrasound is definitive. Alpha fetoprotein should be additional and this should be done testing every 6 months. So dear friends, how to group screen these patients? These patients should be considered. Depend on the view scores are available, which is busy. I'm not going to. So all cirrhotics coming to you every 6 months, you have to evaluate for them with ultrasound plus minus alpha protein. So we need to screen for the SCC and we have to do the surveillance for the SCC. Screening is the defined test. Surveillance is a periodic systematic assessment. So you have to remember these two terms. Screening for the NAS, surveillance for the SCC should be done. So any person of NAS, if his family history and other things are there high, if he is a lean NAS which is more in Eastern India, if he is having associated B, C or alcohol, then we should consider these persons at high risk to be screened. So remember, SCC can be curable if detected early. So our aim is to early detections. Otherwise, we have to go for the curative ways, treatments, palliative is tests or downstage for the treatments. So when you consider SCC, now think of the natural history. So as we are seeing a patient of cirrhosis in our clinic, if he is not having decompensation, he may tolerate up to 9 years. Any decompensation, the survival goes down only to 2 years. SBP less than 1 year. Refractory ascites less than 6 months. If hepatic encephalopathy 1 year, HRS is few weeks to months. So dear friends, please take this slide to your heart. Any cirrhosis patients, once decompensation is a red flag sign. If develops one by one decompensations, they are becomes median survival less. Hence, the clue is to go for the early transplant. So, I've tried to know transplant is two types. Liver transplant is live donor or the cadaver donation. And transplant is needed as a life saving. It is a quality of life improvement and overall improvement of the outcome. So long-term survival has now improved drastically. You can see 25 survival is more than 50%, which is the fear of all doctors in our life, even common man also, that the transplant is not going to make out. You can see that transplant can give survival up to 50% at 25 years, whereas a cirrhosis diagnosis survival is only 10 years. And that quality of life is also better. So when to shift the patient, that's called as minimal listing criteria. That means any person having child 7, that is B or C, portal hypertension related bleed, any single episode of a SBP, if it is ascites is refractory, if he had encephalopathy at any point of time, liver cancer at any time, has developed jaundice or INA, that is synthetic dysfunctions, and this should be considered. And this is a score developed by me for the SLA patients, that is R score. We consider this. For the cirrhosis, we consider MELD-based score 30. And these are other models also should be considered. That is the CTP score, the MELD score, and it has been considered for these decisions. And few conditions where the score does not apply, you have to remember also, because most people think that this score is there. So if SCC, if hepatopulmonary syndrome, if portopulmonary hypertension, if quality of life is poor, if the polycystic liver disease is there, or this person has severe pruritus, recurrent cholangitis, severe fatigue in case of osteoid liver disease, or when you consider multiple, suppose patient liver and kidney transplant, here we should not consider the MELD scores, has to go as soon as possible. So why the risk of delaying transplant is because of increasing sarcopenia, high disease, kidney function may progress, SCC may progress. At any point, they can develop life-threatening sepsis or the bleed. And expenses, you can say direct expense on continued care is more. Post-LT prolonged care in a sicker care cohort will be expenses more. Patient may not make it to transplant. Indirect cost is more than the direct cost. Hence, once the transplant is justified, it is needed, has to go for. This is the criteria as we have already discussed. Indications as everybody aware of, I'm not going to. This is considered for the transplant. Then important thing, I want to highlight 2 slides only. A cirrhosis patient coming to what we have to see. Fibroscan is used most widely, but remember it is needed as a point for the diagnosis, but not for cirrhosis. Once it is diagnosed, and in case of decompensed cirrhosis, it has no value. So try to dissuade the person to go for repeated fibroscan testing unless he is not diagnosed. One, and then simple important is the nutrition. Nutrition is never a low protein, never the salt should be allowed, liquid restriction should be related, and fat carbohydrates should not be restricted unless he is obese or diabetes something there. Small frequent feed is the clue for this group of patients. They need early morning, and let's see, early morning as long as he avoids to take something, and at the bedtime he should sing thing. And the myths of having turmeric, fat, boiled food, oily food should be kept out. That is more important for the nutrition. Drugs, you have to remember in prescribing to a cirrhosis, NSAID, antitubercular drugs, valproids, few antibiotics, particularly macrolide group drugs, amoxicillin group of drugs, antifungal drugs should be in your checklist that they should be avoided. And also warn your patients not to take any complementary medications, herbal products or dietary supplements because they cause liver worsening immediately. Just to share just at the end, artificial intelligence has come a big way in the management of liver disease. You can see this has now become diagnostic to prescribing and predicting. In liver disease, it addresses all across the spectrum, cirrhosis, SCC, and complications transplants. This is one of my articles recently I have presented, how we can define cirrhosis patients to go for a mortality. You can see I have done 80,000 patients data, a simple algorithm. The patient has to see the INR. If INR is more than 1.8, they have at a high risk. If it's AD or SLF, they should have a more risk. And this is simply a curve is showing more than 90% accurate and is better than all the available parameters, that is CTP MELD also. So now artificial intelligence is coming big way, and over the time it will help. And as all our physicians, you can see the infection diagnosis, prediction, prevention, and drug interaction also you can do by this. ICU care has been also modulated by this use of algorithm of AI models. Progression of sepsis you can predict before based on these models. So the future of artificial intelligence healthcare is on the best of natural language process, rule-based experts, and robotic automation. They all has come up, but still it's drawback, and we need to consider a lot of things in our part. And obviously, the doctor or the clinician should rely upon this to go for. Hopefully, in future we can consider this way how you going for, like you have done the Tesla car now, and at the same time you leave your brain in the hospital, you enjoy on the road, and the hospital taken care by the attendants. Thank you.
What a question. Excellent presentation, Professor Ashok Chaudhary. But I have one doubt. Hepatic encephalopathy, you said supplementation of zinc. What is the role of zinc over there? And what is the dose?
Yeah, zinc normally dose is up to 50 milligrams thrice daily you can give. The zinc is one combination of micronutrient, one, two, it relevance to the potassium, and third, it is needed for the integration into the cell synthetic functions. So that is why the zinc is become an essential part in case of hepatic encephalopathy on regular follow-up.
20 days.
How long should we give?
There is no limit. If your patient is having recurrent encephalopathy, you have to continue regularly. If it is hepatic encephalopathy once, at least 6 months to 1 year, you have to give supplements.
One more thing is that we have many patients of CA who are having malignant ascites. We are just palliative care, like we are tapping and giving albumin.
Yeah.
How long can we continue like that?
In malignancy?
Yeah, malignancy. Those who cannot afford liver transplant, nothing.
No, which malignancy?
Hepatocellular carcinoma or secondaries?
No. In secondary, there is albumin has no role with non-cirrhotic ascites.
Okay.
So if it is malignant ascites, you don't need to treat with the albumin. If SCC is there, then ascites albumin correction is needed just to manage his electrolytes and AKI. So that way. So as long as simple rule of managing ascites, irrespective of SCC, in a cirrhosis is that ascites get mobilized. So if you are able to ascites get mobilized, then you can stop. That is one part. Then second is that when you are giving diuretics to a cirrhotic with ascites, if it is SCC, if you are not going to treat SCC, then the ascites mobilization will be very less. So hence you have to think on the logistic way, because SCC is a cause for having portal hypertension. It will aggravate ascites. So you have to, only albumin role will be in that case is to prevent the complications of diuretics, because albumin helps in hyponatremia. It helps in making the BP on the better side, and it prevents the cramps. So in that case, only you have to give. If you are not able to treat SCC, then it is up to you how long you have to give. But the rule dictum is that as long as ascites is there, as long as you are giving diuretics, albumin should be supplemented.
Per day, how many bottles can we infuse?
No, albumin, two things. One is in hospital and is OPD follow-up. The recommended regimen is 40 grams per week. That means 2 bottles per week. But most of people cannot afford. So what do we do that? We do weekly once till we get a appreciable control. That is one. But one beauty part is that albumin should always be given in a hospital setup. So when a patient is admitted to you, it is better to give him daily as long as he is under you, so that honestly to avoid any stay. But albumin, there is no upper limit. The dose calculated is per kg body weight. Suppose a person comes to you with ascites, there is 2 gram per kg body weight. If you think of that way, then every person should need around 4 bottles. That is not practical. That is the Western data. So what we do is that weekly once, and if he's get admitted, we give daily if it's needed. And third, if there are no OPD follow, then see the conditions. You can make a titration according to the cost as well as the logistics also. But otherwise, it is weekly once is okay, and that is 20 gram.
So beautiful. Ashok, I thank you. We are proud that you are a product of our institution. As usual, you are a brilliant orator. I have heard your talks previously. And during 75, by 75. And really, we are proud that we are having you in this session. And I wish you flourish further and become an international figure. Okay, and that time I have heard this talk is as good as that time you gave in 75 and 75. Okay, we are so much proud of you and thankful to you. I hope we will meet you regularly. And wish you all the best.
Thank you, sir.
And thank you very much.
Thank you. And I also take opportunity to thank Dr. Anesh Dingra. He has delivered a brilliant speech to you. And hope Lord Jagannath bless all of you.
Thank you, sir.
Good afternoon, all the students and participants in the quiz competition. Now we are having a very interactive and very wide and very much informative quiz competition. Now I request Dr. Niranjan Mohammed sir, Assistant Professor, Department of Medicine, DMC Scholar, to your quiz master, he is conducting the quiz on the round. Now I request Professor Dr. Sriram Bhaskar, Professor Department of Medicine, IIM Hospital, to moderate this session. And I also request Dr. Aradhana Sahuna, Assistant Professor Department of Medicine, SPMC Scholar, to moderate the session. Now, the mic is over to me.
Rules only 2 minutes. 2 minutes. After 1 minute. Thank you all, the delegates and other dignitaries, those who are present here. We are going for an exciting session today at the end of the scientific fiesta. Probably this is the most interesting one among all the topics because it contains everything what we have learned in last 2 days, and we'll be conducting this in next half an hour. I think you should go through the rules. There are 30 questions, in 3 sessions. First round, second round, and third round. First round is MCQ type questions where it will be given only 1 minute. The moderator, the quiz master will read out and give around 30 seconds for you to decide what to give, and you have to write down your name, the phone number if possible, the institution, and then only numbers after the question you are answering. Don't double write or any scratch, put any scratch there. So you have to put a single sentence and number only. Secondly, the second round can be second round and third round can be given 2 minutes because these are lengthy and descriptive, and he will be giving only after completing the question. The 2 minutes will be counted and we're going to give the answer. We'll be collecting all the answer papers after all the questions over after maybe 30 minutes or so, and we'll be again discussing about the answers. Again, he will be discussing about the answers, and possibly we can take the participation of all the audience so that what is the probable diagnosis or possible best possible answer among us among the question. So over to you, Niranjan, for
last but one row, please maintain distance. You're sitting close by.
And please don't use your mobile phone for any information from internet.
You're not participating.
We are not participating. Come here, other side. You can't help the other. जो मैंने पार्टिसिपेशन करना थी और गाइड करूँ ये कौन करते हैं. Thank you, sir. At the outset, I would like to thank Professor Dr. John Panda, sir, who gave me the opportunity to have a part of this session. And first of all, I would like to thank Professor Bharasa and Aradhana, who are the moderator here. So, in last 2 days, we have already exhausted session of academics. Now, you have all participated in paper presentation and poster as well as all the session in Hall A and Hall B. Now is the time for assessment. How you have improved by this 2 day session? Most of the questions are also there. So already, sir has already explained the rules and regulations. There are only option A, B, C, D. You have to write a single answer. Don't overwrite, don't erase it.
Okay. First round is single line question and single answer. Second round is lengthy type question. Third round is only OSCE type questions. Okay. No electronic device will be allowed there, and no discussion, no whispering. Only PG students are allowed. All the SR and other senior faculty should guide this session. Okay, start kariye.
Okay, we should start, and the time starts now.
सेटा कोन सेट बसी करिया नोट जेटा जे जोनी बस
ये कर देबी तमे सेठी तुमको शो करिवनी तर सीट तमे एठी बस बस वेट बस
स्टार्ट सुन रहे कौन था Question 1, start. CRRT is preferred in patients with hyperkalemia, uremic syndrome, severe hypotension, severe metabolic acidosis. Only one answer.
Those who are joining recently, they can go take their papers and can join without any disturbances. Please take your papers and write down your name and institute from where you have come, and you can participate. But we cannot repeat the question again. This is the first question.
I can wait for 1 minute again for. Write your name, college and year. यहाँ पर आप अलग करिए. This is last. छाड़ी बसो. छाड़ी.
At least 2 seats apart.
At least 2 seats apart.
Okay, please repeat.
Now I am repeating this question. CRRT is preferred in patients with hyperkalemia, uremic syndrome, severe hypotension, severe metabolic acidosis. Next question. In patients with IgA deficiency, which antibody is used to screen for celiac disease? Option A, anti-endomysial antibody. Option B, anti-TTG IgA antibody. Option C, anti-DGP IgG antibody. Option D, anti-gliadin antibody. You have to choose most appropriate and a single answer.
Time over.
Next question. In continuous glucose monitoring device CGM, from which side blood glucose level is taken? Arterial blood, venous blood, interstitial fluid, capillary blood. Next question. In revised international staging system RISS for multiple myeloma, which of the following is not a component? Serum beta 2 macroglobulin, serum ALP, serum albumin, serum LDH.
I can take his microglobulin.
That is microglobulin, macron है. There is a spelling mistake.
Hello.
Next question. In Gold's criteria for severe COPD, which of the following is correct answer? FEV1 by FVC less than 0.7 and FEV1 is less than 30%. FEV1 by FVC 0.7% and FEV1 is more than equal to 30%. FEV1 by FVC less than 0.7 and FEV1 is less than 20%. Option D is FEV1 by FVC less than 0.7 and FEV1 is more than equal to 50%. Choose which is the most appropriate answer.
Time over.
Next question. In long-term adverse effect and efficacy of new drug can be tested in which of the following phase of clinical trial? Option A phase 1, B phase 2, C phase 3, D phase 4.
Time over.
FDA approved angiotensin 2 drug to treat septic shock is serelexin, nesiritide, giapreza, omecamtil mecarbil.
I move.
In the latest 2020 SCLS AHA guideline, which of the following is not approved drug for use in cardiac arrest? A is amiodarone, B lidocaine, C vasopressin, D epinephrine.
I move.
According to the NASP generic code for the pacemaker, position 2 stands for A, chamber sensed, B, response to sensing, C, chamber paced, D, rate modulation. Which anti-nuclear antibody pattern in immunofluorescent test, indirect immunofluorescent test is specific to systemic sclerosis? Speckled pattern, centromeric pattern, rimmed pattern, nucleolar pattern. Next. Now second round, we can give 1.5 minutes. Okay? Start. A 75-year-old man was admitted with diagnosis of SCS. He had a similar episode in 3 months back. He was on aspirin, telmisartan, metformin, glimepiride, and atorvastatin. What should be the LDL target according to the European Society of Cardiology 2019? Option A, less than 55. Option B, less than 65. Option C, less than 70. Option D, less than 100 milligram per deciliter. No discussion. Next question. A 55-year-old acute stroke patient on injection altiplage for thrombolysis. Suddenly, he developed acute complication for which the doctor advised him icatibant, which is a newer epsilon aminocapric acid, B, fibrinogen concentrate, bradykinin B2 receptor antagonist, C1 esterase inhibitors.
Next, a 21-year-old man diagnosed with diabetes for the first time. He has family history of diabetes. A diagnosis of MODI is made. On further investigation, it was revealed that there was an abnormal LFT and renal cyst in ultrasonography. Which gene is likely to be mutated in this patient? HNF1 alpha, B HNF4 alpha, C HNF1 beta, D PDX1. Which of the following parameter is not consistent with pre-renal AKI? Option A, urinary osmolality more than 500 milliosmol per kg. Urinary sodium more than 20 milliequivalent per liter. Plasma blood urea nitrogen is to creatinine ratio more than 20. FeNA is less than 1. Choose appropriate answer. Next question. Which is not a characteristic of diffuse idiopathic skeletal hyperostosis (DIS? It is a non-marginal desmophyte, B flowing candle wax sign, C loss of disc space with ossification of disc space, D absence of sacroiliitis. Which is not a characteristic?
Next question.
Next. What is the side effect of the calcineurin inhibitor CNI, which binds to the cyclophilin, which then inhibits calcineurin used in immunoprophylaxis in cardiac transplant as well as nephrotic syndromes? Side effects are hypersensitivity reaction, gum hypertrophy, leukopenia or cytopenia, delayed wound healing. CNI that bind to cyclophilin receptor, that is very important. Next question. Which of the following is not favoring for the diagnosis of pulmonary arterial hypertension, PAH? Option A, vascular pruning on chest X-ray. Option B, increase PCWP. Option C, RAD on ECG, right atrial. The right axis deviation in ECG, palpable S2. Not favoring the diagnosis of PAH.
Next question, sir.
Next question. A 12-year-old child presented with anemia, elevated LDH and reticulocytosis after a viral infection. Peripheral smear shows hemolytic anemia. He has a Donat-Landsteiner antibody positive. What would be the diagnosis? Option A, PCH, paroxysmal cold hemoglobinuria, warm antibody autoimmune hemolytic anemia. Option C is hereditary spherocytosis. Option D is cold agglutinin disease. Next. A 30-year-old gentleman was exposed to sandblasting in a confined space for more than 5 to 6 months. And he now presented with severe breathlessness. What is the characteristics HRCT finding in this condition? Option A, signatrine sign. Option B, tram track appearance. Option C, crazy paving appearance. Option D, tree inward appearance. Next. In a cohort study design, the relative risk is more than 1. This indicates relative risk is significant. Incidence of unexposed is higher than that of exposed. Incidence in exposed is same as that of unexposed. Incidence in exposed is higher than that of unexposed. Now this is a third round. There is a pictorial presentation. OSCE pattern. Start. 1 minute. A 40-year-old man presented with upper GI bleed in emergency OPD. After initial resuscitation, upper GI endoscopy was performed and identified the cause of upper GI bleed from this picture. Esophageal varices, Mallory steer, CMV esophagitis, vascular ectasia. Next question. Rumac Matthew nomogam is used in which of the following conditions? Salicylate overdose, paracetamol overdose, barbiturate overdose, ethanol intoxication. Rumac Matthew nomogam. Next question. This clinical sign is seen in TAPVC, AR, pulmonary arterial hypertension, VSD. There is a giant foot photograph. No discussion. Next question. This characteristics MRI picture is seen in PSP, MSA type C, MSSC, Hutchinson disease, Hall-Varden-Spart disease. This is a sagittal MRI view. Next question. This classical ECG findings is seen in VSD, PAH, ASD, Brugada syndrome. There is arrow in specific region. देखाउछि
The typical finding and year mark.
Already there is a arrow over the typical findings in specific leads to just identify in which cardiovascular condition the sign is seen. Next question. A 12-year-old boy presented with low frequency hearing loss and blurring of vision. On routine testing, there is 3+ proteinuria on urinary examination and hematuria. All of the following are true about this condition except it is an X-linked disease. It recurs rarely after transplantation. It is associated with anti-GBM antibody. It had worse prognosis. What is the disease and correlate this? Next, a 60-year-old man with history of long-standing emphysema, complaining of palpitation. On examination, he had tachycardia with irregular rhythm. Which of the following modalities of treatment is ineffective in the management of this condition? There is ECG with arrow mark. One is beta blocker, B is electrical cardioversion, C is verapamil, D is AV nodal ablation. Identify the disease, then choose the appropriate answer. There is long-standing emphysema with palpitation and irregular rhythm. Next, in relation to this image, which of the following drug binds preferentially to SST5 receptor? ocreotide, ocreotide lar, lanreotide, pasreotide lar. Next, in 65-year-old male, complaints of hypertension presented with sudden onset, altered sensorium with blood pressure to 20/110. The patient recover after lowering the BP. See the image and diagnose this condition. CVST, SAH, press, CVA infarction. CVST cerebral venous sinus thrombosis. Subarachnoid hemorrhage, press, CVA infarction. Last question. A young male presented with tingling and numbness in her hand and feet. On examination, there was sensory motor polyneuropathy. Some additional findings were depicted there. Identify the condition. There is a tonsil, yellow tonsil, yellow to red color tonsil. One is large tonsil, Kikuchi-Fujimoto disease, Tangiers disease, X-linked adrenoleukodystrophy, D is Kawasaki disease. There is tingling and numbness, sensory motor polyneuropathy with large tonsil. Close कर दो. Session is closed now.
You can collect.
Collect.
Now you can collect some of our faculties who are present can collect the answer sheet. Then we will discuss.
Asa boss bitru.
There are 3 prizes to be won, first, second, and third. The first prize is possibly 10,000.
Yes.
Yes.
A special announcement for this winner. First prize there is a rupees of 10,000. Second prize is 8,000 and third prize is 6,000. If there will be a overlap, there should be a tiebreaker. I plan there will be a tiebreaker. If it is not possible, then we can give both also.
We have got tiebreaker questions also for those who are eligible participant. We'll see after the marking and how much they score, and then we'll decide what to do. And the prizes will be distributed in the valedictory session. So kindly be present there. The certificates will be handed over later. Those who are participated, those who are the winners.
Sir, answer will be announced now.
The answers would be now discussed and it will be declared now. So the scorer can have a paper with them and they can count. ଗୋଟେ ପେପର ଦେଇଛନ୍ତି ତାଙ୍କୁ ସେ ଆନ୍ସର ଗୁଡ଼ା ଗୋଟେ ପେପରରେ ଆନ୍ସର ଲେଖିଦେଲେ ଆମେ start. So I think we can go ahead with the discussion for answers and you can match what you have done.
क्वेश्चन केमित थिला हां
Brainstorming.
ओके कोड अच्छे येगा खोल लो
I think according to the MCQ rules, those who we do in MCQ quizzes, 40% are direct questions that can be answered like pictorial and all, and 30 to 40% again brainstorming, and few are out of the box. So he has managed it well, and all the questions are judiciously placed, and I can say that this is a good number of questions, and we can have a good response from the postgraduates.
ଏଇଠି ଥିଲା ବା ସବୁ ପଳେଇ ପୁଣି ଅଟୋ ହେଇଟି ଅଛି ବା ଏଟା ସେଟା ନେଇ ସେ ତଳେ ସେପଟ
एक मिनट कौन चली छे এটা আসছে এইটা আসছে সেটা পড়ে আসছে
এটা তো এইটু আপন आंसरটা जो ଥିଲା
Go ahead, no one discuss.
Check for that. এটা आंसर তো silent. What is the answer? Hypotension is the answer.
नहीं पट्टी नहीं चाहिए ऊपर खाली ये कर दो स्क्रीन में स्टडी आ रहा था मजीद को तो
बस CRT is preferred in patient with severe hypertension with cardiovascular instability. Okay, we have already trained in some days back in our department. Next question. What is the question answer? Anti-DGP in presence of IgA deficiency, anti-TTG IgG and anti-DGP deaminated gliadin protein IgG are screened for celiac disease. Deaminated gliadin protein IgG. There is no option for anti-TTG IgG. Option C is the correct answer. What is the answer? Interstitial fluid. Option C. काली जे एडी प्रेजेंट थिबो से जानथिबो काली इंसुलिन वर्कशॉप रे कोइ छी ना माइनस फर्क नहीं in revised international what is the answer There is serum beta 2 microglobulin, albumin, and LDH are there. Alkaline phosphatase are not there. Gold's criteria. B is the correct answer. 30 to 50. 30 to 50 means more than 30. Less than 50. Severe. ठीक अछि. What will be the answer? B is the correct answer. Phase 1 is the safety and acceptability. Phase 2 is the long-term safety and dosing and early indication of the efficacy. Phase 3 is the effectiveness. What will be the answer? Giapreza, a synthetic vasoconstrictor peptide indicated in shock. What will be the answer? C. Okay. What will be the answer? Chamber sensed. Chamber paced with the 1, 2 is chamber sensed, response to sensing and rate modulation and multi-site pacing. Correct answer will be A. What will be the answer? A is the speckle. किसी प्रॉब्लम अच्छी की? हाँ? Second round.
For second question, the celiac disease screening antibody. Pilla for question lekha hai in the presence of IgA deficiency. Question lekha hai deficiency.
What will be the answer? A will be the answer. In very high risk category, when there is ASCVD, type 2 diabetes with target organ damage, here there is SCS. There is high risk category. Kali eta presentation भी ହେଇଥିଲା. Kali hall रे present ହେଇଛି eta. Okay. What will be the answer? B. Answer will be C. Bradykinin B2 receptor antagonist. Here there is a sudden complication, sudden acute complication is angioedema. Angioedema, not the bleeding disorder. Icatibant is a drug of choice in angioedema. No. Icatibant is not a C1 esterase inhibitor. It is indicated along with C1 esterase inhibitor. It is a bradykinin B2 receptor antagonist. Hereditary angioedema, both are given. Icatibant is a bradykinin B2 receptor antagonist type of drug. Different. What will be the answer? It will be C. 1, 2, 3, 4, 5. Renal cyst and diabetes are in HNF beta, hepatocyte nuclear factor 1 beta. All are from Harrison. Most of the table. What will be the answer? Answer will be B. Okay. Which is not a characteristics of dish. Answer will be A. No. Answer will be C. This is from Harrison. Intervertebral disc space are preserved and sacroiliitis and apophyseal are going to be normal. There will be flowing wax signs. Intervertebral disc space will be preserved, but there is calcification and disc place in bamboo spine. Okay. What will be the answer? Gum hypotrophy. Cyclosporin bind to the cyclophilin receptor as well as tacrolimus bind to the immunophilin FK605, not 505, 605. Side effects of the cyclosporin and gum hypertrophy, hypotrichosis. Option is B. What will be the answer? Huh? A. What will be the answer? C. Silicoproteinosis, pulmonary alveolar proteinosis, and pneumocystis staris pneumonia, and sometimes organizing pneumonia. There is a peculiar picture in crazy babying appearance. What will be the answer? Oh no. D. When there is a relative risk is 1, the incidence of exposed and unexposed are same. When is more than 1, incidence of in exposed is higher than that of the unexposed. When the relative risk is less than 1, incidence in exposed is lower than that of unexposed. Third round. What will be the answer? Mallory is due. Okay. What will be the answer? Paracetamol overdose. At the timing of paracetamol injection as well as concentration of paracetamol and further toxicity, liver toxicity is depicted in this picture. What will be the sign? Lincoln sign. AR. Is Abraham having Marfan syndrome. What is Lincoln sign? There is popliteal artery pulsation, severe popliteal artery pulsation. There is a movement of the foot during this position. Which sign it is? Hummingbird sign. There is atrophy of midbrain and maintenance of the pons as well as the tail of the hummingbird is depicted in medulla. This is a classical hummingbird sign in ESP. What is the sign? Crochet sign. Answer will be ASD. There is a notching in R wave in inferior lead. 2-3 ABA. Crochet sign. What will be the disease? Alport syndrome. And what will be the correct answer? What will be the correct answer? C will be the correct answer. What will... Except. There's some twisting, small twisting is there. What will be the diagnosis of the ECG? Multifocal atrial tachycardia, MET. Although there is emphysema, beta blocker is contraindicated, but it is effective. Verapamil and evinodal ablation and beta blocker are the drug of choice. But electrical cardioversion is not indicated in this MET. ଆସିବ ତ ଦିଟା କ୍ୱେଶ୍ଚନ୍ ଥିଲା
या पे अनाउंस करते हैं समस्त को ऑडियो की जरूरत है
ଏବେ ସଲା ପରେ ଆନାଉନ୍ସ କରିଦେବା ସେମାନେ ଯାଆନ୍ତି ଯେମାନଙ୍କ ହିସାବ କରିକି
ଟିକେ ଆନାଉନ୍ସ ଯଦି ଇଏ ହୋଇଗଲା ମୋଡ୍ସ ହୋଇଗଲା ସେମ୍ ମାର୍କ ହୋଇଗଲା ଦେଖିବା ଦେଖିବା
हां सर ସେଇଟା
ହଲରେ କ'ଣ ହେଉଛି ଏବେ
ଭ୍ୟାଲିଡିଟି ବି ହବ या पर
ହଁ ହବ ଆସିବ Question number 8 in relation to the acromegaly, which will be the drug preferentially bind to the somatostatin receptor type 5? Pasireotide LAR. This is a recent book of Harrison, previous edition, new edition. Pasireotide LAR is a multi-receptor ligand with preferentially SST5 binding site. Press. Option is C. What will be the option? Tangiers disease. The high density lipoprotein selectively reduced, and there is a mutation in ATP binding cascade transporter 1 gene that produce characteristics of splenomegaly, cardiovascular disease, and swollen and orange color pharyngitis, pharyngeal tonsil, and peripheral neuropathy. This is from brain textbook. Thank you all.
I think you could have assessed how much you have done, and we request you to please go to the hall A for valedictory section and further academic events, and we will announce there who are the if there is a tie between the participants, then
we'll try to call back.
We'll try to call back those who are tiebreaker only. Only 2 to 3 participants, those who have been having a tie-up situation, we will call them. And again, our questionnaire. We have another set of questions for them only, if there is a tiebreaker in any position. Okay, you can move to hall A for further academic events and valedictory session.